Hello everyone. So am I live? Just give me a quick confirmation if we are live. Just give me a quick confirmation. Just give me a quick confirmation. Hello. So we'll start in 5 minutes. We'll wait for few other people to also join in, and then we'll start. So very good evening to all of you. Wait for few other people. Hi Ritika. So how was the test? Those who attended the test and are live with us, how was the test? Tell me in the comment section. Okay. So welcome to today's radiology TND, and the purpose of this class today is to brush up your radiology as far as your previous year questions are concerned, because I don't want that you get your previous year questions wrong. Okay, so new questions are fine, new concepts are fine, but previous year questions we have to master for our NEET PG. So this will be a short class. I'll try to cover it within a hour, at max 1.5 hours. So like you can relax and watch it simultaneously also. Hello girl boss. And even later in the time, so let's say you are going to sleep, you just want to revise, brush up radiology, especially your previous year questions. So you can just watch it at 1.5x or 2x, and your PYQs as far as your NEET PG will be covered. So I have included both INICT and NEET PG PYQs here. Okay, and all of them are mostly image based questions. Few questions from radiotherapy are also there, which are factual based, and we know that physics and radiotherapy are also asked nowadays. INICT had a lot of weightage from radiology, around 8 to 10 questions were there from radiology per se. So you cannot afford to let go of radiology. Okay, so take it as a revision class, take it as a class where you revise all clinical branches per se. You'll get some questions from medicine also correct, orthopedics, obs, gynae, surgery also correct. So I have included a mixed bag of questions here. Now a quick word about the strategy. So I want to briefly talk about the strategy first, because we know that only 10 days are left now. Okay, 10 to 11 days for some people, depending upon when you watch this video. So let's talk about how you should go ahead with these last 10 days. So first of all, now is the time to revise entire theory. Okay, all you have been studying for the past 1 year now, this is the D day, this is the D time for you to revise your entire theory. And I am peculiar in this regard that I do not suggest any student to attempt any grand test in these 10 days. Okay, no grand tests. Whatever grand tests you gave, they are sufficient. There is no point of giving any grand tests right now. I would even say that solving questions per se now is not so important, because now the main aim is to keep all the theory fresh in your mind. Okay, so take it as last 10 days to revise your entire theory. So what to revise? So if you have made revision notes as your revise karne wala material, do that. Okay, if you have attended some short courses to revise in the last 10 days, do that. If you are someone who was reading main notes and have highlighted important stuff, do that. If you have, conceived your material in first aid, now is the time to read it all over again. Okay, so depending upon where you have conceived your material, revise each subject in 1 day for the last 10 days. Okay, so some few smaller subjects, especially minor subjects, you'll have to club them with a major subject. So make a combination of a major plus minor subject to revise. Now what should be the order of revision? Okay, so what I did during my preparation, I'll tell you, and it helped me really well. So if these are my last 10 days, during the first few days, revise your clinical stuff, clinical subjects, because they are more concept based. You can afford to not mug up those things. Okay, so first few days, let's say 4 days you revise clinical subjects, then 4 to 5 days. Okay, then the next 2 days you revise minors, and 3 to 4 days you revise, or let's say you are clubbing a major and a minor, so 4 to 5 days, first 4 to 5 days, and the next 5 to 6 days you revise first and second year, and all throughout club a minor subject with a major subject. Okay, so revise theory of all 19 subjects in these last 10 days. That is my heartiest request to all of you. If you do that, I'm sure you'll get a good rank in NEET PG, because everything will be fresh in your mind. So with that, we'll start our radiology test and discussion. I hope the test was not so tough. It was a previous year question based test, so I hope most of you got the answers correct. So first question, can you tell me the answer? What have you guys marked for the as an answer for the first question? ठीक है, Chitam Reddy Sai is saying 2. Okay, a 16-year-old patient with history of spinal TB was brought to the hospital with low-grade fever, dull backache, persistent flexion of hip joint. So there is a fixed flexion deformity, and the patient has a history of fever and backache. Okay, what are we given? We are given a CECT, contrast enhanced CT of the abdomen. Which plane is this? This is a coronal section. And where am I seeing the pathology? I am seeing that this is an abnormal collection. This is an abscess which has collected within the muscle. It is lifting up my left kidney. So which muscle am I talking about? This is my psoas. This is my psoas muscle. So this has been labeled by second. So this is the whole extent of the psoas muscle. Uh, let me just outline the psoas muscle for all of you. This is the psoas muscle. Okay, and this is the abscess that has formed here. Okay, this is the psoas abscess, right? Now, can someone tell me what will be the treatment here? Patient has low grade fever, hospital के साथ आया, fixed flexion deformity. What will be the treatment here? What will be the treatment in this case? Gayatri, can you tell me the treatment? I'm audible, right? Am I audible? My voice is audible, right? So whenever incision and drainage, no, incision and drainage will not be an option. Why? Because this is a deep seated abscess. This is a deep seated abscess. Okay, so yes, eventually you'll have to give ATT. The definite treatment is an ATT, but you know, whenever there is an abscess, you first have to drain the abscess, and ATT will go on simultaneously. Why do we have to drain? Why not only ATT? Because in an abscess, the medicines can't percolate. An abscess is, you know, a source of infection. The patient can get into septicemia if we don't drain the abscess. So we have to drain the abscess first. So if in the question, the options are start ATT and send the patient home. Second option is drainage of the abscess by a pigtail catheter and overlap with ATT. Third option is incision and drainage and overlap with ATT. And fourth option is take the patient to OT, open it and explore. What will you do? The answer here will be a pigtail drainage. Pigtail drainage with ATT. Okay, what is a pigtail catheter? Basically, this is a drainage catheter. Through an ultrasound guidance, we put a catheter within this drainage, within this abscess, and drain the abscess out. Okay, so this is a minimally invasive treatment. Through an ultrasound guidance, you put in a needle, place the catheter within the abscess cavity and drain the abscess. This is the treatment for a psoas abscess. Incision and drainage. When will incision and drainage be the option? This is an option for your superficial abscesses. Superficial abscesses. Okay, for example, your skin abscess, your breast abscess, a thyroid abscess, a cervical abscess, a lymph node abscess, which is superficial. There you do an incision and drainage. Remember, for a superficial abscess, we do not do a pigtail catheter insertion. We do not do a catheter insertion, catheter drainage. Pigtail is not done for superficial abscesses. ठीक है, I hope this concept is clear. Please don't mark incision and drainage as a treatment of choice for this question, nor you should mark open in an OT, do a lavage and start ATT. The treatment is a minimal invasive treatment by a percutaneous catheter. Sometime instead of a pigtail, you'll be given a percutaneous catheter. Percutaneous catheter. Okay, basically we are inserting a catheter through the skin under ultrasound guidance and starting ATT simultaneously. That will be the answer in this question. So the answer is B. The second is the psoas muscle which has been marked. Okay, now quickly let's briefly see the Pott spine. So imaging in Pott spine, let's quickly revise. So we know that TB, especially spinal TB, which is referred to as the Pott spine, for that the hallmark is a paradiscal infection. And what is the spread of TB? The spread is subligamentous. Now, what do I mean by that? So paradiscal mean that the vertebral body adjacent to the intervertebral disc. The violet is my intervertebral disc. The vertebral body highlighted by the yellow, highlighted by my yellow color. This is the site of infection first. So the disc is spared early in the infection. Okay, and initially the paradiscal part, the part of the vertebral body adjacent to the intervertebral discs, these are first infected. And slowly the infection goes posteriorly in the epidural space and anteriorly just beneath the anterior longitudinal ligament. And from here it spreads superiorly like this. So that is what is meant by a subligamentous spread. Okay, subligamentous spread. And the hallmark, and why do you say that this is an infection and not a neoplasm? Why are we saying it as a new infection? Because there are abscesses. Abscesses are characterized by these ring enhancement. You see that these are the areas of abscesses. Ring enhancing areas. These tell that this is an infection. Abscesses are hallmark of infection. Okay, so this is my tuberculosis. Again, see this image. The intervertebral disc is spared and the adjacent vertebra, they are involved. Okay, you see that the spinal cord is normal, that is not involved. And on post contrast enhancement, there is enhancement of this infected vertebra. This is my hallmark of Pott spine. Similarly, if you do an axial MRI, so this is an axial T1 weighted MRI. Here we see that this is the normal spread of the infection. The vertebral body is destroyed here. You see it is destroyed and the infection is spreading adjacent to the vertebra, and this is my subligamentous spread. From here it will ascend into the other vertebra. So this is hallmark of Pott spine. Now how do you diagnose? Diagnosis is always and always by a tissue sampling. So if you are given this image and a similar history has been given to you in the question, a low back ache, low grade fever, sometimes paraparesis can happen if the spinal cord gets compressed, and on imaging you see that there is destruction of vertebra. Number one, destruction of vertebra. Kyphosis. Sometimes what happens that because of this destruction, the vertebra gets collapsed. So there is focal angulation of the vertebra. This is known as gibbous. So there is vertebral destruction. There is gibbous deformity. Okay, and this is hallmark of TB. Next step is a tissue sampling. So you will ask for an FNAC. You will ask for an FNAC from this. And how will I do an FNAC? I'll put in a needle in the paravertebral space here and take out small tissue for sampling. Okay, so this is the whole management of a case of Pott spine. I hope this was clear to you. So good evening, Rahul. Now someone is asking how many PYQs will I cover? So I'll cover 3 to 4 years of PYQs of NEET PG. So in around we have around 25 previous year questions and associated theory. So what I have done, that similar previous year questions that are asked, I've clubbed them together into single question in the form of its discussion. Okay, so we'll cover at least 3 to 4 years of PYQs of radiology, mostly NEET PG. I have also added few NICT PYQs also here. Okay, so we'll try to finish it quickly. Okay. Now let's move on to the next question. A 12-week-old child presented with fever, cyanosis, fatigue. His chest X-ray is shown below. What is the most likely diagnosis? So 2-week-old child, cyanosis, fatigue, fever, X-ray. Cyanosis, whenever an X-ray of the child is given, an infant, especially a neonate or an infant, cyanosis. And typical named X-ray you get, what are you suspecting? You're suspecting congenital heart disease. So tell me quickly in the comment section, what have you guys marked? Kya hai answer? Easy question. Yes, so the answer is easy. Total anomalous pulmonary venous return, TAPVR we call it. Okay, and what is the name of the sign? Yes, it is figure of 8 or snowman's sign, snowman's heart. Good, somebody has replied with the emoji. So that is a new way of answering questions nowadays. I like that. Good. Now quickly we'll cover the important named heart signs, especially congenital heart disease. Tell me 1, 2, 3. What is number 1? What is number 1? Sign and diagnosis. Quickly, sign is boot-shaped heart. Now someone is saying that सर ये क्वेश्चन नहीं आते अब यार. माउंट फूजी साइन भी NICT में लोग बोलते थे नहीं आएगा. ठीक है, वन लाइनर्स लोग बोलते थे कि नहीं आते हैं. कुछ भी हो सकता है नीट PG NICT में. वी कांट assume that one liners will not come now. Exam pattern may change, may not change. It is you can't predict it. Okay, what we want to do in today's session, we just want to cover previous year question, so at least these questions we don't get wrong. So boot shaped heart, diagnosis is TOF. Second, now tell me in boot shaped heart, what thing you should look for always and always in an X-ray. Suppose this is looking like a boot, okay, but what thing you should always look in the X-ray to confirm that there is pulmonary oligemia. The pulmonary blood flow is less. So you see that the pulmonary vessels are not so well visualized. That means there is a pulmonary oligemia. Pulmonary oligemia. Why? Because there is reduced pulmonary blood flow. And why does that happen? Because TOF, one of the component is your pulmonary stenosis. That's why always and always in TOF you will get reduced pulmonary blood flow. ठीक है. Now second, फटाफट tell me what is the sign, what is the diagnosis. Cyanosis है patient को. Quickly, second sign, diagnosis. Now second is my card. What are you seeing? First of all, you are seeing that there is cardiomegaly. ठीक है. Second thing, you are seeing that the pulmonary vessels or the lung fields are black. So again there is pulmonary oligemia. Okay, cardiomegaly with pulmonary oligemia, what should come to your mind? The diagnosis is Epstein's anomaly. अब कुछ लोगों को लग रहा है कि this is Egon string. No, this is not Egon string. Egon string will have a narrow pedicle. Here the pedicle is so wide. Here the pedicle is so wide. This is not Egon string. What is this appearance? This is box-shaped heart. Box-shaped heart. Sign is box-shaped heart. Yes, diagnosis is Epstein's anomaly. Now, what is the characteristic of Epstein anomaly? It is right atrial enlargement. Right atrial enlargement. This is characteristic of Epstein anomaly. And how do you judge right atrial enlargement on a chest X-ray? You look at the height of the right atrium. Okay, you do not look at the width. You do not look at the width. You always and always look at the height of the right atrium. If it is enlarged, the right atrium is always and always enlarged. Good. Now let's see the third image. We've already covered in today's class. What is the diagnosis? Sign, figure of 8, and or snowman's heart. Diagnosis is supracardiac TAPVC. ठीक है. So first set of x-rays we are done. Snowman's heart, box shaped heart, boot shaped heart. ठीक है. Now among these, the first two, TOF and Epstein anomaly, these are causes of reduced pulmonary blood flow with cyanosis. ठीक है. TAPVC also has cyanosis, but here the pulmonary blood flow is increased. Okay, now let's come to the next set of x-ray. Now tell me the diagnosis here. You see that the pulmonary blood flow is increased and cyanosis तो है ही, सारे hearts में cyanosis तो है ही. ठीक है. So what else do you see in this image? You see that the pedicle is so narrowed. The pedicle is so narrow. This is what we call as an egg on string appearance. The diagnosis here is, name of sign is egg on string, and the diagnosis is TGA. ठीक है, transposition of great arteries. Now tell me quickly, name of this sign. What is these three images showing to you? Tell me quickly. What is the diagnosis? So Pihu is asking, is there a way to identify infracardiac TAPVC? So infracardiac TAPVC, the abnormal channel goes and opens it into the portal vein or the IVC. Okay. Now in such a situation, remember, the X-ray may be normal. Only thing you will see on an X-ray is a cardiomegaly and increased pulmonary blood flow. That is all you will see. But apart from that, you will not see the abnormal channel because it is going below the diaphragm and attaching into the portal vein or the IVC. So as far as imaging is concerned, cardiomegaly and increased pulmonary blood flow. But remember, infracardiac TAPVC is the worst prognosis amongst TAPVC. That has very high chances of getting obstructed. That abnormal channel can get obstructed and the patient can undergo into a frank pulmonary edema. So amongst TAPVC, which one has the worst prognosis? Infracardiac TAPVC. This has the worst prognosis because this abnormal channel can get obstructed. This is the most common subtype to get obstructed and pulmonary edema can happen instantaneously. ठीक है. Now फटाफट tell me these three set of images. What is the diagnosis? 1, 2, 3. 1, 2, 3. What is the diagnosis? So what is this first image? This is a barium swallow. And barium swallow क्यों किया होगा हमने? Because the patient would be having dysphagia. ठीक है, dysphagia के लिए the investigation of choice is a barium swallow. Now on a barium swallow, we get an external indentation on the upper esophagus. Now why am I saying external? Because this is an obtuse angle. This is forming an obtuse angle with the esophagus. That is why it is an external compression. So we know something is compressing from behind. And if we look at the CT scan, what is compressing from behind? Tell me, what is the diagnosis? This has been asked in this year's INI CT. Tell me the diagnosis. Yes, good. It is URSA. This is dysphagia lusoria. ठीक है. This is my abnormal aberrant right subclavian artery, which is going behind the esophagus. This is my esophagus, which I am marking with purple. This is esophagus. The trachea has already been marked with T. So URSA goes behind the esophagus. So you should never ever see a vessel posterior to the esophagus on a thoracic inlet CT scan. Okay? If you see a vessel going posterior to the esophagus in the upper thorax CT scan, you should think of URSA or aberrant right subclavian artery. The diagnosis is URSA. Now this is also shown in this VRT image. So which type of CT is this? This is a volume rendered technique, 3D image. 3D image, this is the arch. The first one is my brachiocephalic trunk. The second one is my left common carotid. And this is also, this is the branch of brachiocephalic trunk. This is your subclavian artery, which is also originating, and this abnormal channel which is originating at the last, this is my URSA. Okay, aberrant right subclavian artery, dysphagia lusoria. Now, since we are talking about abnormal arch variants, this question has been asked in INICT this time. So very important for you to know other important arch variants also. So tell me, can anyone tell me what variant is this? 1, 2, 3. We'll cover 3 variants. Tell me what is the answer for the first question? What variant is this we are talking about? Arch variants. Arch variant anatomy. Fatafat tell me. Can anyone tell me what is the first? So this is what is known as a bovine arch. Bovine arch, very commonly seen. That is why it is a potential question for your upcoming NEET PG or your November INICT. Okay, very common variant this bovine arch is. Now what is a bovine arch? So normally what happens that the left common carotid has a separate origin, and our left common carotid has a separate origin. But in a bovine arch, the left common carotid also has a common origin with your brachiocephalic trunk. So here brachiocephalic trunk and left common carotid artery, they have a common origin like this. So from this trunk you are getting your left common carotid also, and you are getting your brachiocephalic trunk. This is my bovine arch. Okay, I hope this was clear. The left subclavian has a separate origin like this. This is my left subclavian, which has a separate origin. So in bovine arch, your left common carotid and brachiocephalic has your common origin. Good. Now second, tell me what is the second diagnosis? I have also shown a representative anatomy diagram also. So first of all, is this URSA? Is this abnormal right subclavian artery? Is this URSA? Tell me in the comment section, tell me in the live chat, is this URSA? Now this you have already read. I'm sure you have read this term. You have read this variant in embryology when you're talking about, origin of formation of arch and its branches. Yes, Abhirami, you're right. This is not URSA. Why? Because you do not see any vessel going posterior to the esophagus like this. So this is not URSA. We are very clear on this. So I am giving you few options. Tell me what is the correct answer. So my options are, number 1, I've given you URSA. Second is your double aortic arch. Third option I'm giving you right aortic arch. And fourth option I'm giving you this bovine arch. So what is the answer? Yes, the answer here is a double aortic arch. Okay, remember this image. This is how a double aortic arch looks like. Okay, double aortic arch, you will see a abnormal arch encircling both the esophagus and the trachea and forming an inverted V sort of image. So this is how my double aortic arch looks like. Now in contrast, the next image, the third image that I am showing to you, this is how your right aortic arch looks like. This is an image of a right aortic arch with an aberrant left subclavian artery. So this is forming a V. This is forming a V. Inverted V was in double aortic arch. So double aortic arch has inverted V, and this is the third image here. This is my right aortic arch with aberrant left subclavian, aberrant right subclavian, sorry, URSA, yeah, with aberrant right subclavian. Okay, so this is how my right aortic arch looks like. So right side aortic arch will go like this inferiorly. Don't make this as your right aortic arch. The second image is not your right aortic arch. Here the orientation of the arch is like this, which is normal. In addition, you have extra arch. That is why it is a double aortic arch. Okay, so these are a little tough to understand. Okay, but once this question has been asked, URSA has been asked, so right aortic arch, double aortic arch can also be asked as far as your radiology is concerned. If this question comes, I hope you will get the correct answer, and you will be the few of the people who will get these questions correct. Okay, now fatafat tell me the last aortic arch anomaly. What is this known as? A patient comes to you with hypertension. There is difference in blood pressure reading in both the upper limbs. You are given a chest X-ray. What is the diagnosis? Sign and diagnosis. Yes, the diagnosis is coarctation of aorta. The name of the sign is sign of 3. Okay. There is this constriction. Okay, this is the constriction of the aortic arch at the isthmus. So the answer here is coarctation of aorta. 3 sign. Okay. Now let's move on to the next question. A patient presents with abdominal pain and distension. An X-ray was taken which showed dilated bowel loops as given in the image below. What have you guys marked as the answer? Identify the segment involved. Okay, abdominal pain and distension, you see that there are dilated bowel loops. And we are very clear that this is my small bowel. Why? Because there are these complete septations that I can see within these bowel loops. So these are my small bowel loops, right? And in the upper abdomen, what will I mark? I'll mark them as jejunum. Okay? Ileum is usually in the pelvis. Ileal loops are in the pelvis. In the upper abdomen, we have the jejunal loops. So don't mark them as ileum. The answer here is jejunum. Okay? Now this is how we differentiate between a small and a large bowel. So the small bowel will have these complete septations. Complete septations make them small bowel. And these second point, that small bowel has complete septation and they are in the center of abdomen. Small bowel loops are in the center of abdomen. Whereas large bowel loops are number A in the periphery. And second, they will have these incomplete hoftrae, these incomplete septations. ठीक है. This is how you differentiate small versus large bowel. Now tell me, which is the investigation of choice for intestinal obstruction? Investigation of choice for intestinal obstruction. What is the answer? Options are ultrasound, barium enema, CCT, MRI. No, laparotomy is not the investigation of choice. X-ray abdomen is also not the investigation of choice. Yes, investigation of choice is your CCT. Intestinal obstruction है patient को clinically. First of all, intestinal obstruction is a clinical diagnosis. You want to confirm it. Why do you get a CCT done? Because you want to see the level of obstruction. कहाँ पे obstruction है, क्या cause of obstruction है, that you want to see with the help of a CCT. That is why CCT is the investigation of choice for intestinal obstruction. Now, one of the causes of intestinal obstruction in children is intussusception. Intussusception. And tell me, what are these? What are the signs that I am seeing here? So first of all, investigation of choice for intussusception and gold standard for intussusception. What is investigation of choice? What is gold standard? Yes, the sign is donut sign. Sometimes also known as target sign or bowel within bowel. Bowel within bowel appearance. Okay, what is this sign known as? The second image, this is my pseudo kidney sign. Investigation of choice is good. I'm very happy that you guys have answered this. Investigation of choice is ultrasound. Gold standard is barium enema. Okay, what is this showing? This is a barium enema. What sign am I seeing here? Name of the sign. So this is claw sign. Yes, this is claw sign. This is like a claw. This is a claw sign. And this tells you basically the importance of claw sign is that this is the level where the bowel has telescoped into the bowel. This is the level of intussusception. So what treatment do we do? So for ileocolic intussusception, ileocolic, which is the most common type of intussusception by the way, or you have colocolic intussusception, what you do is you do hydrostatic or pneumatic reduction. The treatment is hydrostatic or pneumatic reduction. So what do we do here? We put in a Foley's catheter here, okay, or a barium enema tube here, and put barium enema, or sometimes we just inflate it with air also. That is known as pneumatic reduction. So either barium reduction or pneumatic reduction, and with the pressure of the air, slowly this intussusception will reduce. This is what is known as pneumatic reduction. This is the treatment of choice. This is the treatment of choice, remember, for ileocolic and colocolic intussusception. Now question can come, and a very important question, especially because this is now very commonly done in central institutes, and you know, questions now overflow from INICET to NEET PG. There is not much difference in the paper pattern right now, so you have to prepare like a central institute for NEET PG as well. So the treatment for ileocolic and colocolic intussusception is a pneumatic reduction or a hydrostatic reduction. If both are given in the option, you will choose pneumatic reduction. And what are the contraindications? When will you not do this? If there are indications or if there are signs of it is contraindicated. Pneumatic reduction is contraindicated if there are signs of perforation. Okay, so let's say the patient has guarding or rigidity that is given to you in the question, or there is air under the diaphragm which is given to you in the question. Then you will not do pneumatic reduction because the perforation will increase. Here you will have to do a surgery. Okay, I hope this concept is clear to you. You will not make any mistakes as far as intussusception management is concerned. Yes, if perforated, then lap. We'll have to do laparotomy. Now the next question. A child with acute ALL undergoes prophylactic irradiation prior to autologous hematopoietic stem cell transplant. Which of the following is least affected? So an easy question basically is asking which organ is most radio-resistant. Okay, that is what the question is asking. Yes, the answer here is good. Gayatri, good. The answer is here is neuron. Neuron are most radio-resistant. So let's just quickly tabulate the radio-resistant and radio-sensitive various questions that are asked. So cell cycle, most radio-sensitive phase of cell cycle, it is G to M, followed by M phase. So basically most sensitive is the transition between G2 phase and M phase. So that is why we write it as G2M. But if it is not given, then you write it as a mitotic phase, because whenever the cells are rapidly dividing, they are more prone to radiation. Okay? Now most radio resistant phase is my S phase. Now tissue, most radio sensitive tissue, this is my bone marrow. And radio resistant, this is my nervous tissue. Organ most radio sensitive are my gonads. ठीक है, radio resistant is my vagina. Not my vagina, is vagina. Then blood cell, most radio sensitive blood cell, WBC. Radio resistant blood cell, platelet. Right? So I hope this was clear. Radio sensitive, radio resistant, cell cycle, tissue, organ and blood cell. Okay? Straight away question, ratna hai, no concept, just have to mug it up. Now let's briefly talk about fractionated radiotherapy, because this was asked in previous year FMG. So this is a recent FMG question and a very good question that was asked in FMG, and hence it can be always and always be asked in NEET PG. So that is fractionated radiotherapy. Now we know that whenever we talk about radiotherapy, we don't give the entire radiation dose in one sitting. We divide it into multiple fractions. So let's say the total dose. Let's say the total dose that is to be given in for a particular tumor is around 60 gray. Okay. So typically what is a normal fractionation? What is a normal division? That we divide this 60 gray into 6 sessions. Okay. And per session, and these 6 sessions are divided into weeks. So you will have 6 weeks, and per week you will give them in 5 days per week. Okay. And per day usually around 2 gray is given. Okay. So per day 2 gray you give 5 days a week, per week you give 10 gray, and for 6 weeks total dose comes out to be 60 gray. So what is a normal division or a normal fractionation? It is 1.8 to 2.2 gray per fraction, and you give 1 fraction per day, and you give 5 fractions in a week. So you give radiation for 5 days in a week. So you have weekends off. So even radiotherapy patients have weekends off, but you as a resident will not get a weekend off. Okay. So remember, weekends are off for patients undergoing radiation therapy. Saturday, Sundays are holiday. Why? Because in Saturday and Sunday, we want that the cells who were in your S phase, S was the radio resistant phase, and hence the cells which were in the S phase, they will not be killed. So when on Saturday and Sunday, these cells will convert into G to M phase, and that is why, you know, fractionation is given so that radiation therapy is more effective. The cells which were in the S phase come into G to M phase and get killed when we give radiation the next day on Monday. So that is what my normal fractionation is. Now, sometimes the question that was asked was regarding hyperfractionation, accelerated fractionation, and hypofractionation. So, if we have understood the normal fractionation, what is my hyperfractionation? Hyperfractionation means I am giving more fractions. Okay, I am giving more division. So per day I am giving 2 sessions, morning, evening, morning, evening. So you give morning, evening sessions each day, and again you give therapy for 5 days in a week. So since you are dividing a per day dose into morning, evening, per session dose will reduce. Okay, I hope this concept is clear. So per session your dose gets reduced. How low? Only 1 to 1.5 gray per session. So morning 1.1.15, evening 1.15. You give it for 5 days in a week, then Saturday Sundays are off. Okay. Now what is accelerated fractionation? Accelerated means that you are reducing the total time. And how will you reduce the total time? If you give on Saturdays also. Okay, here you give it 6 days a week. You are giving the same dose of 2 gray, you're giving 6 fractionations per week. And hence your total radiation dose, total radiation duration reduces to 5 weeks from your 7 weeks. This is accelerated fractionation. And finally, hypofractionation. So somebody is asking, sir, ये टॉपिक भी पढ़ना होता है क्या? जो मैं पढ़ा रहा हूँ ना, बस रेडियोथेरेपी में बस वो पढ़ लो. अभी नीट पीजी से पहले रेडियोथेरेपी अलग से मत पढ़ना, जो मैं पढ़ा रहा हूँ बस वो पढ़ लो. हाइपोफ्रैक्शनेशन मींस पर फ्रैक्शन हम ज्यादा डोज दे रहे हैं. ठीक है, ज्यादा डोज दे रहे हैं पर फ्रैक्शनेशन. सो इसमें अराउंड 2.2 ग्रे पर फ्रैक्शन देते हैं हम डोज, एंड टोटल ड्यूरेशन इसमें भी कम हो जाएगी. क्यों? क्योंकि हम पर फ्रैक्शन ज्यादा डोज दे रहे हैं. सो टोटल ड्यूरेशन कम हो गई. हाउ? 6 वीक्स की हो गई. नॉर्मल फ्रैक्शनेशन में 7 वीक्स की थी. ठीक है, इस एग्जाम्पल में टोटल डोज 70 ग्रे है, इसलिए 7 वीक्स हो रहा है. ठीक है, ये मत बोलना कि सर आपने तो 6 बताया था, पिछले एग्जाम्पल में 60 ग्रे था, इसमें 70 ग्रे है. तो हाइपरफ्रैक्शनेशन, हाइपोफ्रैक्शनेशन एंड एक्सीलरेटेड फ्रैक्शनेशन में योर ड्यूरेशन विल रिड्यूस. ठीक है, सो आई होप दिस फ्रैक्शनेटेड radiotherapy is clear to all of you. Any doubt in this, please tell me. चलो इसकी स्नैपशॉट ले लो. ठीक है, नोबडी रिमेंबर्स द हाफ लाइफ. एक दिन एग्जाम से पहले ही पढ़नी है ये, मॉर्निंग ऑफ द एग्जाम में पढ़े ना. जस्ट टेक अ स्क्रीनशॉट ऑफ दिस. आई एम नॉट एक्सप्लेनिंग दिस बिकॉज देयर इज नथिंग टू एक्सप्लेन दिस टेबल. प्योर रट्टा. जस्ट टेक अ स्क्रीनशॉट एंड लेट्स मूव ऑन. Now let's come to the next question, an easy question for all of you. Abhirami is saying, can you make a tabulated version of this? तो चलो ठीक है, tabulated version में आ लेते हैं. So normal fractionation क्या है? Normal fractionation is 1.8 gray to 2.2 gray per fraction. ठीक है, and we give it 5 days per week. ठीक है, अब if we talk about hyperfractionation, this is less than 1.8 gray per day per fraction. Here you give it morning, evening, and again you give it for 5 days a week. But इसमें फायदा नहीं हो रहा है with respect to your duration. बस आपकी per dose रेडिएशन कम लग रही है, सो साइड इफेक्ट्स कम होंगे. ठीक है, ये एडवांटेज है इसकी. हाइपोफ्रैक्शनेशन में क्या होगा? हाइपो में आप मोर देन 2.2 ग्रे पर फ्रैक्शन दे रहे हो, एंड यू आर गिविंग इट फॉर 5 days a week. सो आपके टोटल नंबर ऑफ डेज, टोटल नंबर ऑफ वीक्स कम हो जाएंगे. सो देयर इज रिडक्शन इन द ड्यूरेशन. The duration reduces. चलो नेक्स्ट क्वेश्चन फटाफट. आइडेंटिफाई द इमेजिंग मोडालिटी गिवन बिलो. ठीक है, इजी पीजी, नॉट मच टू बी डिस्कस्ड हियर. आंसर इज पेट सीटी स्कैन. ठीक है, आई होप ऑल ऑफ यू गॉट दिस आंसर करेक्ट. Now the main purpose is to discuss other investigation. ठीक है, cerebral blood flow scan क्या होता है, सिस्टम में भी क्या होता है, फुल बॉडी सीटी क्या होता है, फुल बॉडी सीटी नाम की कोई चीज होती भी है कि नहीं होती. ठीक है, दिस इज व्हाट वी वांट टू डिस्कस. So first of all, let's talk about full body CT only. So yes, full body CT is an investigation, is a modality that is done. Can someone tell me in the comments for which pathology do we do a whole body CT? होल बॉडी सीटी फॉर किसके लिए करते हैं, किस पैथोलॉजी के लिए मोस्ट कॉमनली यूज करते हैं? नॉट मेट्स. मेट्स के लिए करते देखा है किसी को होल बॉडी सीटी? पेट करते हैं ना मेट्स के लिए, तो मेट्स के लिए तो पेट करते हैं ना. होल बॉडी सीटी करते देखा है किसी को? लिम्स भी होते हैं इसमें, लिम्स इमेज में कटे हुए हैं, लिम्स भी होते हैं, लिम्स ऊपर होते हैं ना पेशेंट के, तो इसमें दिख नहीं रहे आपको. यस, आंसर इज मल्टीपल माइलोमा. गुड. होल बॉडी सीटी इज डन फॉर मल्टीपल माइलोमा. कैन समवन टेल मी फॉर मल्टीपल माइलोमा व्हाई डू वी नॉट डू अ पेट स्कैन? पेट में भी तो दिख जाएगा मल्टीपल माइलोमा, नहीं दिखता है कि नहीं दिखता पेट में मल्टीपल माइलोमा? Can we see multiple myeloma on a PET scan? Yes or no? No. No, because multiple myeloma has plasma cell infiltration. Has plasma cell infiltration. There is no osteoclastic or osteoblastic activity that we see in multiple myeloma. And हमें पता है पेट स्कैन में रैपिडली कौन कौन सी सेल्स दिखती हैं. बोन स्कैन या पेट स्कैन में हमें वही मिलती हैं, ऑस्टियोक्लास्टिक या ऑस्टियोब्लास्टिक सेल्स, जहां पर रैपिड टर्नओवर होता है बोन्स पे, दैट इज पिक्ड अप. ठीक है, सो मल्टीपल माइलोमा में प्लाज्मा सेल इन्फिल्ट्रेशन इज नॉट पिक्ड अप ऑन पेट स्कैन. दैट इज व्हाई वी डू अ होल बॉडी सीटी. That is why we do a whole body CT, or also we do a whole body MR. Whole body MR is done for multiple myeloma. ठीक है, होल बॉडी एमआर के और भी इंडिकेशन है अपार्ट फ्रॉम मल्टीपल माइलोमा. द सेकेंड इंपॉर्टेंट इंडिकेशन इज योर डर्मेटोमायोसाइटिस. ठीक है, सो होल बॉडी एमआर, होल बॉडी सीटी इज डन फॉर मल्टीपल माइलोमा टू सी द लिटिक लीजन्स. ठीक है, डोंट गेट दिस क्वेश्चन रॉन्ग. Now the another option that was given to us was cerebral blood flow scan. Now cerebral blood flow scan का दूसरा नाम है CT perfusion. So CT perfusion most commonly रेडियोलॉजी में कहाँ पर यूज होता है? We use it in stroke imaging. We use it in stroke imaging, right? Now stroke imaging में when do we use a CT perfusion? Can somebody tell me in stroke when do we use a CT perfusion? This is a very good question. No, for multiple myeloma, investigation of choice is not whole body CT. तो इन्वेस्टिगेशन ऑफ चॉइस तो फ्लो साइटोमेट्री ही है आपका, बट मतलब बोन मैरो एस्पिरेशन एंड फ्लो साइटोमेट्री ऑब्वियसली। बट आपको पता है ना जो कि अभी क्राइटेरिया है क्रैब क्राइटेरिया में, आपका जो क्रैब क्राइटेरिया है उसमें बोन इज बी इज बोनी लीजन ना। हाउ डू यू सी बोनी लीजन? यू सी इट ऑन होल बॉडी और होल बॉडी सीटी और होल बॉडी एमआरआई। ठीक है। अर्लियर व्हाट यूज्ड टू हैपन, अर्लियर स्केलेटल सर्वे यूज्ड टू बी डन फॉर सीइंग बोन लीजन्स, बट इट सेंसिटिविटी इज वेरी लेस। स्केलेटल सर्वे की सेंसिटिविटी बहुत कम है। तो अब होल बॉडी सीटी या होल बॉडी एमआर होता है टू सी योर बोन लीजन्स। एंड वैसे भी अभी क्रैप क्राइटेरिया तो नहीं यूज होता, यू यूज माइलोमा वर्किंग ग्रुप का क्राइटेरिया आता है ना, माइलोमा इंटरनेशनल माइलोमा वर्किंग ग्रुप क्राइटेरिया फॉर मल्टीपल माइलोमा। ठीक है, ये याद करके चलना। सॉलिटरी प्लाज्मा साइटोमा, एमगस, मल्टीपल माइलोमा में क्या क्या डिफरेंस हैं क्राइटेरिया में, दिस इज इंपॉर्टेंट। हाँ, so we were talking about stroke imaging, CT perfusion, and somebody has said that we use stroke imaging में CT perfusion to see the severity of stroke. No, for severity of stroke, tell me a clinical score. Tell me a clinical score and a CT score. Yes, clinical score is NIHSS, National Institute of Health, Stroke Severity Scale, NIHSS scale. CT score, tell me, what is the CT score for stroke severity? What is the CT score for stroke severity? The name is aspects. Aspects. Aspects stands for Alberta Stroke Program CT Severity Score. ठीक है, aspects with the CT severity score. ठीक है, so when do we use CT perfusion? Now we know that from the onset of stroke, tell me what is my window period. Tell me the window period for number A, IV thrombolysis, and number B, mechanical thrombectomy. Yes, PU, you are right. We use CT perfusion to see which part is salvageable. Yes, good. But in which situations do we want to see the penumbra? I'm sure you're talking about penumbra imaging, the salvageable part of the brain. In which situations do we want to see the salvageable penumbra? First, tell me, yes, the window period for IV thrombolysis is 4.5 hours. You are very right. What is the window period for your mechanical thrombectomy? What is the window period for mechanical thrombectomy? No, 24 hours is not the official window period. So tell me according to AHA guidelines. AHA guidelines. Okay, I'm giving you options. 6 hours, 12 hours, 16 hours, 24 hours. 5.5 hours is not an option. I'm sure this is covered in your medicine. ये तो पूछते हैं, important point है, this is an important point. Window period for mechanical thrombectomy. भाई देखो, स्ट्रोक इंटरवेंशन रेडियोलॉजिस्ट करते हैं, ठीक है. सो मतलब टेल मी द करेक्ट आंसर. आई डोंट वांट एमबीबीएस स्टूडेंट्स टू गेट दिस क्वेश्चन रॉन्ग. Mechanical thrombectomy, AHA guidelines, what is the stroke window? What is the window period? According to AHA guidelines, the window period is 6 hours. ठीक है. So if a patient comes to you within 6 hours of your stroke onset and on an imaging you have a large vessel occlusion and a stroke, you don't need to do a CT perfusion. You can directly take the patient to the cath lab, do a mechanical thrombectomy and retrieve the clot. But the condition is the patient should come within 6 hours. Now I am talking about a condition that, let's say the onset of stroke happened. So this was the onset of stroke. The patient came after 6 hours. Patient came after 6 hours. Now, according to AHA guidelines, this does not fall into my window period for mechanical thrombectomy. Now, after 6 hours, if I want to do a mechanical thrombectomy, now I want to see that what is the salvageable tissue left. Now I want to see the penumbra. This is where the penumbra imaging comes into picture. Because within 6 hours, a lot of tissue would have gotten infarcted. After 6 hours, if the patient has come and if I do a thrombolysis, the patient will bleed. So I want to see what is the salvageable tissue which has not gotten infarcted but has only ischemia. Ischemia is there but infarction is not there. That is where my penumbra comes into picture, and for that we have CT perfusion and MR perfusion. So if my CT perfusion or MR perfusion shows good penumbra, that is penumbra is present, now I can still do mechanical thrombectomy up to 24 hours. Up to 24 hours. But for up to 24 hours to do a mechanical thrombectomy, you have to do a CT perfusion. This is the whole concept. Okay, I hope you understand this concept, that after you want to do, after 6 hours to do a mechanical thrombectomy, you have to do a CT or an MR perfusion, see the area of penumbra and retrieve the clot. Within 6 hours, directly you can take it for mechanical thrombectomy. Okay, I hope this concept was clear to all of you. Now, how do we see ischemic penumbra? So this is what is interesting to me. So ischemic penumbra will have normal cerebral blood volume. It will have a normal cerebral blood volume, but it will have a reduced cerebral blood flow. Okay, very, very important. And what else will be raised? Both the mean transit time and the time to peak. Just remember these two things. MTT is your mean transit time, and Tmax is time to peak. Both of these should be increased. So my cerebral blood flow is less, but my volume is normal. Okay? Whereas in an infarct, my volume will also be less, and my cerebral blood flow will also be less. Both the mean transit time and Tmax are increased here as well. Okay, I hope this concept was clear. In an ischemic penumbra, my cerebral blood flow is reduced, but my cerebral blood volume is normal. Why? Because the area is getting filled up by the collaterals. That is why if I still retrieve the clot, that area has not yet gotten into infarction and the patient will not bleed. But if in an infarct I retrieve a clot, that area is already infarcted. If now I open the artery, that area will start bleeding. Okay, because that has gone into infarction. That is what is the importance of your CT perfusion imaging in stroke. ठीक है, I hope this concept was clear to you. Very very important concept. If you get this concept right, this concept will stay with you throughout your MD. Now finally, two new investigations that I'm giving you. ठीक है, these two are new investigations which I have not, one of them is a new investigation which I have not taught in my class regularly, but a potential question now, because this is again very commonly done. And I see radiology questions getting tougher and tougher. You see ultrasound contrast agent, I taught it in the class, ठीक है, never asked previously. This year NICT ultrasound contrast agent was asked, question was asked. Now tell me, what is this investigation? Can someone tell me what this investigation is? Okay, which joint is this? Which joint is this? I've already written. कौन सा joint है ये? Modality बता दो. जॉइंट विद कंट्रास्ट, ठीक है. कौन सी मोडालिटी है? सीटी है, एमआरआई है, अल्ट्रासाउंड है, फ्लोरोस्कोपी है. यस, इट इज अ शोल्डर जॉइंट. ठीक है, गुड. दिस इज एन एमआरआई. ठीक है, तो यहां तक करके आपने बता दिया कि एमआरआई है सर शोल्डर का, आई एम हैप्पी. बट दिस इज अ लिटिल नेक्स्ट स्टेप, थोड़ा एडवांस पढ़ा रहा हूं आपको. दिस इज व्हाट इज नोन एज योर एमआर आर्थ्रोग्राम. दिस इज योर एमआर आर्थ्रोग्राम. ना उसमें क्या करते हैं हम? परक्यूटेनियसली एक नीडल डालते हैं, यहाँ से एक नीडल डालते हैं अंडर एक्सरे फ्लोरोस्कोपी के अंडर नीडल डालते हैं जॉइंट के अंदर, एंड वी इंजेक्ट गैडोलिनियम. सो वी पुट इन अ नीडल विद इन द जॉइंट. कौन सा जॉइंट यहाँ पे दिख रखा है? शोल्डर, बट रिस्ट का भी होता है, नी का भी होता है, एंकल का भी होता है, एल्बो का भी होता है. यहाँ पर शोल्डर एमआर आर्थोग्राम बता रहे हैं. सो नीडल विद इन द जॉइंट and put gadolinium. ठीक है, सो क्या होगा इससे? जॉइंट हमारा डिस्टेंड हो जाएगा. एंड कौन सी पैथोलॉजीज बेटर दिखेंगी हमें? दिस इज डन फॉर माय लेब्रल पैथोलॉजीज. लेब्रल पैथोलॉजीज, लेब्रम, ठीक है, शोल्डर का जो लेब्रम होता है उसके लिए वी डू एमआर आर्थ्रोग्राम. Now, whenever your shoulder labrum gets injured, what do you get? You get shoulder dislocation. Shoulder dislocation. So, if you are asked investigation of choice for recurrent shoulder dislocation, your answer will be MR arthrogram. Yes, we injected within the synovial joint. ठीक है, so very very important concept, a new thing that I am telling you, potential question for your upcoming exam. ठीक है, this is MR arthrogram. Now this, tell me which investigation is this? कौन सा है? This is my dual energy CT. This is my dual energy CT. So dual energy means I am doing a CT scan at two energies. ठीक है, एक 140 kV पर और एक 80 kV पर. ठीक है, दो एनर्जी से हम सीटी कर रहे हैं. सो दो ट्यूब्स हैं, दोनों ट्यूब ऐसे घूम रही है पेशेंट के चारों तरफ. द गैंट्री हैज टू ट्यूब्स. इफ देयर आर टू ट्यूब्स, दिस इज नोन एज ड्यूअल सोर्स ड्यूअल एनर्जी. इफ देयर आर टू ट्यूब्स, जैसे कि इस इमेज में है, ए में है, दिस इज ड्यूअल सोर्स ड्यूअल एनर्जी सीटी. कभी कभी क्या होता है कि एक ही ट्यूब ऑल्टरनेट स्विच करती है 140 एंड 80 kV पर. दिस इज नोन एज माय फास्ट स्विचिंग, फास्ट kV स्विचिंग. एंड दिस इज माय सिंगल सोर्स, एक ही ट्यूब है, सिंगल सोर्स ड्यूअल एनर्जी सीटी. कभी कभी फिल्ट्रेशन होता है एट द लेवल ऑफ डिटेक्टर, एट द लेवल ऑफ डिटेक्टर, कि एक डिटेक्टर हाई 80 केवी को पिकअप कर रहा है, सॉरी लो केवी 80 केवी को पिकअप कर रहा है, और एक डिटेक्टर 140 केवी को पिकअप कर रहा है. सो दिस इज नोन एज ट्विन बीम सीटी, ट्विन बीम ड्यूअल एनर्जी सीटी. ठीक है, आपको क्या याद रखना है, ड्यूअल एनर्जी सीटी का पर से, नॉट इंपॉर्टेंट सिंगल सोर्स, ड्यूअल सोर्स, ट्विन बीम. ड्यूअल एनर्जी सीटी कौन सी पैथोलॉजीज के लिए हम यूज करते हैं, वी यूज इट फॉर गाउट मेनली एंड फॉर रीनल स्टोन्स. ठीक है, चलो फाइनली हम कुछ न्यूक्लियर मेडिसिन स्कैन्स के बारे में फटाफट पढ़ेंगे. न्यूक्लियर मेडिसिन स्कैन, बिकॉज वी हैड टॉक्ड अबाउट सेफ्टामीबी स्कैन. नाउ टेल मी, सेफ्टामीबी स्कैन इज यूज्ड फॉर which pathology? So cephtamebi scan versus cephtamebi spect, क्या फर्क है? So cephtamebi scan is a 2D image, 2D scan. Spect is a 3D image, 3D scan. ठीक है, used for parathyroid, both are used for parathyroid imaging. ठीक है, good. If among the two you have to choose one, which will you choose? You will choose a 3D image, SPECT. Why? Because SPECT is like a CT. So here you see this is a SPECT image. You can very well see that this is the area of abnormal parathyroid gland. ये चमक गया है. And since it is a CT, you can very well accurately locate कि this is the pathology. So ectopic, that is why advantage of SPECT is your ectopic parathyroid adenoma. Ectopic parathyroid adenoma can also be picked up. ठीक है, whereas 2D इमेज तो एक्सरे की तरह, सो ectopics कभी कभी मिस हो जाते हैं. नाउ टेल मी, these scans, किडनी की बात हो रही है, किडनी के डायनामिक स्कैन्स की बात हो रही है. ठीक है, क्या डायग्नोसिस बन रहा है इसमें? कैन समवन टेल मी द डायग्नोसिस? चलो, किडनी से रेडियो ट्रेसर एक्सक्रीट हो रहा है. ठीक है, सो अर्लियर इमेजेस में हम क्या देख रहे हैं कि जो लेफ्ट किडनी है, ये लेफ्ट है, इसमें ये राइट है. मैं लेबल कर रहा हूँ. ठीक है, मैं लेबल करके बता रहा हूँ कि दिस इज लेफ्ट एंड दिस इज राइट. आई डोंट वांट टू डिबेट दिस. अब DTPA मैग 3 में हम पोस्टीरियरली लेते हैं इमेज. ठीक है, पोस्टीरियर होती है फ्रेम, तो राइट लेफ्ट उल्टा होता है एज कम्पेयर टू अ नॉर्मल एक्सरे. तो दिस इज माई लेफ्ट, दिस इज माई राइट, आई एम टेलिंग यू. तो उसमें क्या दिख रहा है कि जब हम स्टार्ट कर रहे हैं एट 0 to 2 minutes, जो लेफ्ट किडनी है उसमें लेट आया रेडियो ट्रेसर, राइट किडनी में जल्दी आ गया. फिर 2 to 7 minutes में अगेन लेफ्ट किडनी थोड़ी फेंट है, राइट किडनी थोड़ी डार्क है. बट धीरे 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 व्हाट हैपेंस दैट व्हेन आई गो टू 12 to 17 minutes और 20 minutes, then the tracer is getting accumulated in the left kidney. And even if I do a post void scan or a scan 1 hour later, 1.5 hour later, this radio tracer is not getting excreted. So that means there is an obstruction at the level of uretero-pelvic junction. So this is what is PUJ obstruction. Yes, this is left hydronephrosis. Good PU. This is left hydronephrosis. And since I am not seeing the ureter also, that means that there is no contrast in the ureter also. That means the blockage is at the level of PUJ, pelvic-ureteric junction. And the diagnosis is your PUJ obstruction. ठीक है. Now, what are the renal scans that we do? DTPA, MAG3, DMSA. So these DTPA and MAG3 are dynamic scans. ठीक है. Most commonly, if you are asked which is the radionuclide scan to see the renal function, just the renal function. You are asked radionuclide scan to see the renal function. What will you mark amongst these three? No, for function you will not. If the renal function is asked, you will mark MAG3. Why? Because MAG3 is excreted both by tubular secretion and GFR. If you are asked to calculate GFR, then you have to mark DTPA. GFR calculation only, then DTPA. If renal function overall you're asked, then you have to mark MAG3 because you want to assess both tubular secretion and glomerular filtration, right? So the answer here will be MAG3, better than DTPA for renal functional assessment. Now DMSA is a static scan. ठीक है, मतलब डायनामिक का मतलब ये है कि आप 2 मिनट से भी ले रहे हो, 5, 7, 10, 15, 20, पोस्ट वाइड 1 आवर सब ले रहे हो. दिस इज अ डायनामिक स्कैन. ठीक है, स्टैटिक स्कैन क्या है कि आपने एक बार ले लिया बस, कि एक ही इमेज आई. दिस इज माई DMSA स्कैन. दिस इज माई DMSA स्कैन. ठीक है, वेयर डू यू यूज इट? फॉर रीनल स्कारिंग. And in which condition renal scarring is very commonly seen in? VUR, reflux nephropathy. Good, good Bharat. Reflux nephropathy, you want to see renal scar, you do DMSA. So this is my MCU. This is my micturating cystourethrogram, and I'm seeing bilateral hydroureteronephrosis. ठीक है, this suggests that there is VUR. There is vesicoureteric reflux. Now let's move on to the next question. A patient is brought to the casualty following a road traffic accident. What have you guys marked as the answer? Tell me. क्या mark किया answer? A patient brought to the casualty following a road traffic accident. Examination. The patient is conscious. BP is 90/60, so hypotensive. The respiratory rate is 40. Pulse rate is 120. X-ray is shown below. What is the next best step in management? What have you guys marked? Hypotensive है, unstable. Actually option थोड़े गलत हैं. Sorry, I apologize. So if I make it as a needle thoracotomy. Sorry, I apologize for the options. The third option should have been a needle thoracotomy. Yes, then the option answer becomes my C. Needle thoracotomy है, so it is C. ठीक है, अगर स्टेबल होता तो हम चेस्ट ट्यूब डाल देते. ठीक है, so here we see pneumothorax अच्छा खासा. You do a needle thoracotomy. Adults में कहाँ करते हैं needle thoracotomy? 5th intercostal space, mid axillary line. ठीक है, और यही अगर चाइल्ड होता तो हम 2nd इंटरकॉस्टल स्पेस में कर देते. ठीक है, मिड क्लैविकुलर लाइन में. ठीक है, यस, यू विल डू अ thoracotomy followed by a chest tube insertion. Good. Now pneumothorax, quickly we'll see. Best X-ray view is PA expiratory view. Best investigation is NCCT. ठीक है, ई फास्ट में हमें क्या मिलता है? ई फास्ट में न्यूमो स्कैन करेंगे, वी विल गेट बारकोड साइन या फिर स्ट्रैटोस्फियर साइन. ठीक है, इसमें यहाँ पे दिख रहा है आपको न्यूमोथोरैक्स. दिस इज अ न्यूमोथोरैक्स. हियर दिस इज द न्यूमोथोरैक्स. ठीक है, मैनेजमेंट इंटरकॉस्ट अनस्टेबल पेशेंट नीडल थोराकोस्टमी फॉलोड बाय ICD, एंड स्टेबल पेशेंट में डायरेक्टली पुट इन एन ICD. ठीक है, तो न्यूमोथोरैक्स फास्ट में कैसा दिखेगा हमें? एब्सेंस बी मोड पे एब्सेंस ऑफ लंग स्लाइडिंग, एंड एम मोड पे यू गेट योर बारकोड साइन और अ स्ट्रेटोस्फेयर साइन. मोस्ट स्पेसिफिक साइन अगर कोई पूछे ऑफ न्यूमोथोरैक्स ऑन अल्ट्रासाउंड, इट इज लंग पॉइंट. It is my lung point sign, which is the most specific sign. But if someone asks you investigation of choice for pneumothorax, answer is a non-contrast CT. Good. So let's move on to the next question. So this is how my lung point sign which I am demonstrating. Now the signs that we were seeing, so this X-ray में ये plural line जो दिख रही है आपकी, these are sign on erect chest X-ray, but sometimes on supine X-ray, on a supine X-ray, patient most of the time आपके पास अगर आएगा इमरजेंसी में, so he or she will be lying on a stretcher. ठीक है, sometimes this pleural line and pneumothorax is not so well seen. Whenever the patient is lying supine, all the air will come in the front, in the anterior chest, and उस time पर you sometimes are not able to see a very well pleural line separating the air and the lung. So supine X-ray में sign of pneumothorax is your deep sulcus sign. ठीक है, डीप सल्कस साइन इज दैट जो आपको सीपी एंगल होता है, इट एक्सटेंड्स वेरी वेरी डीप. दिस इज अ साइन ऑफ योर न्यूमोथोरैक्स, अ डीप सल्कस साइन. एंड अपार्ट फ्रॉम दैट देर आर फ्यू अदर पॉइंटर्स पॉइंटिंग टू अ न्यूमोथोरैक्स. नंबर वन है ये है कि यहाँ पे आपको सबक्यूटेनियस एम्फाइसीमा दिख रहा है, एंड यू सी द एरोज दे आर पॉइंटिंग टूवर्ड्स द रिब फ्रैक्चर्स. ठीक है, सो डीप सल्कल साइन इज अ साइन ऑफ न्यूमोथोरैक्स ऑन supine X-ray. ठीक है, now we know that अगर air fluid level दोनों ही आ गए, then it becomes hydropneumothorax. So this is my hydropneumothorax, air fluid levels both. Now let's come to the next question. Again an easy question. A 60-year-old female has to undergo radiotherapy for treatment of CA cervix stage 2B. Which is the following is true regarding ionizing radiations? ठीक है, so true statement आपको पता करना है. So GI mucosa is more radio resistant? No, it is sensitive. The radiation at a point is inversely proportional to the square of distance from the source. This is my inverse square law. ठीक है, this is a correct statement. That means कि अगर आपका रेडिएशन का सोर्स ये है एंड आपका पेशेंट यहाँ पे लेटा है ना, सो द एज वी इंक्रीज द डिस्टेंस, ये डिस्टेंस है, एंड पेशेंट को जो रेडिएशन लग रही थी उसकी इंटेंसिटी आई है. दैट मीन्स द इंटेंसिटी ऑफ रेडिएशन is inversely proportional to square of the distance between the source and the patient. This is my inverse square law. So the closer, that means तो skin होगा, skin पे सबसे ज़्यादा radiation intensity होगी. That is why the most common side effect of radiation therapy is skin erythema. ठीक है. Now the next option, normal cells and cancer cells will be equal radiosensitive. No, cancer cells are rapidly dividing, so they will be much more radiosensitive. Endothelial lining of blood vessels are radioresistant? No, they are radiosensitive. So the correct option is option number B. Okay, easy peasy. Now let's move on to the next question. A 25-year-old male, what have you guys marked as the answer? क्या mark किया इस question का answer? 25-year-old male came to the OPD with chronic knee pain for the past 4 months with no history of trauma. No history of trauma. And the patient has chronic knee pain. And 4 months से है. Now, X-ray of the knee has been depicted below. What is the most probable diagnosis and the management of this patient? Tell me what have you guys marked as the answer. ठीक है, चलो बढ़िया है. मोस्ट ऑफ यू हैव मार्क्ड एज बाइपार्टाइट पैटेला. गुड. तो कोई हिस्ट्री ऑफ ट्रॉमा नहीं है, बट हमें एक डिविजन लग रहा है पटेला में. अब यू विल सी कि सर पेटेलर फ्रैक्चर भी तो हो सकता है, बाइपार्टाइट क्यों बोल रहे हो? सो यू हैव टू लुक एट द मार्जिन्स. सो हेयर द मार्जिन्स आर वेरी स्क्लेरोज्ड. देखो वाइट लाइन दिख रही है यहाँ पे, दिस वाइट लाइन, दिस इज माई स्क्लेरोज्ड मार्जिन्स. ठीक है, दैट मीन्स कि ये लॉन्ग स्टैंडिंग ऐसे ही है इमेज. एंड अगर आप जूम करके देखोगे, आई थिंक इमेज थोड़ी ब्लर्ड हो गई है आपके स्क्रीन पे यूट्यूब पे, बट आई कैन सी दैट, अच्छा इस इमेज में दिख रहा है ना, हाँ, दिस इज हाउ बाइपार्टाइट पटेला लुक्स लाइक. सो फर्स्ट ऑफ ऑल बाइपार्टाइट पटेला में द सेपरेट फ्रैगमेंट इज इन द सुपीरोलैटरल एस्पेक्ट. सुपीरोलैटरल एस्पेक्ट. ठीक है, यहाँ पे फ्रैक्चर अनलाइकली है. फ्रैक्चर अगर होता है तो मोस्ट कॉमन फ्रैक्चर इज अ ट्रांसवर्स फ्रैक्चर ऑफ द पेटेला. ठीक है, वो मिड लाइन में होता है ट्रांसवर्स फ्रैक्चर. ये सुपीरोलैटरल में है ओब्लीक फ्रैक्चर. दिस इज रेयर. दिस इज द मोस्ट कॉमन type of bipartite patella, superolateral type, and this is congenital. Why? Because there is failure of fusion of secondary center of ossification of patella. There is no fracture per se, there is just failure of fusion of ossification center. So it is a bilateral pathology. So bipartite patella is a bilateral pathology. That is why you do an opposite limb x-ray. ठीक है, चलो गुड. पेटेला फ्रैक्चर अगर होगा तो हमें ऐसे दिखेंगे. जो मार्जिन्स इसके होते हैं, दे आर वेरी इरेगुलर, दे आर नॉट स्क्लेरोज्ड. सो दिस इज माय फ्रैक्चर पेटेला. एंड इसके लिए हम ट्रीटमेंट करते हैं, टेंशन बैंड वायरिंग कर देते हैं अगर बहुत वाइड अपार्ट हैं. अगर इतने वाइड अपार्ट नहीं है, के वायर्स यूज करते हैं. ठीक है, स्क्रूज भी यूज करते हैं, प्लेट्स भी यूज करते हैं. आई थिंक यू विल कवर दिस इन orthopedics, but most common treatment for them is a tension band wiring. Now let's move on to the next question. A 50-year-old chronic alcoholic male with a history of trivial trauma 3 weeks back came to the OPD with complaints of headache. NCCT head was advised in this patient and the image has been depicted below. What would be the diagnosis? Chalo fatafat tell me. What will be the diagnosis? Easy question है. ठीक है, एक्यूट ट्रॉमा है, हेड ट्रॉमा है. दैट इज माय इन्वेस्टिगेशन ऑफ चॉइस फॉर एनसीसीटी. एंड इसमें वी सी अ ब्लीड in the left cerebral convexity covering the entire left cerebral hemisphere. So it is crossing my sutures. The answer here is a SDH. ठीक है, क्रॉसिंग ऑफ सूचर्स है. ठीक है, तो फटाफट EDH FDH में डिफरेंस बताओ. तो EDH will not cross suture. This will cross suture. EDH will cross midline. FDH will not cross midline. ठीक है, EDH happens in high velocity trauma. FDH happens in trivial trauma. ठीक है, more commonly happens in the elderly. So let's say an elderly fell in the bathroom. Trivial trauma है, तभी FDH हो जाता है. उतने छोटे से ट्रॉमा में ही FDH हो जाता है. ठीक है, this is an arterial bleed, EDH. Most common artery involved is a middle meningeal artery. This is a venous bleed. Most common vein involved is an emissary vein. ठीक है, so brief capsule about EDH and FDH. चलो SAH in comparison कहाँ पे होता है? This is an intra subarachnoid hemorrhage होता है ये. ठीक है, this is not extraaxial, this is subarachnoid hemorrhage. So this is SAH in the sulcus. So this is sulcal SAH. And this is my cisternal SAH. ये basal cisterns को involve कर रहा है. Now most common cause of SAH अगर कोई पूछे, what is the most common cause of SAH? This is trauma. But अगर question है most common cause of non-traumatic SAH, then the answer is berry aneurysm. अगर क्वेश्चन आए इन्वेस्टिगेशन ऑफ चॉइस फॉर SAH, हेमरेज डायग्नोस करनी है बस, देन आंसर इज एन NCCT. बट इफ द क्वेश्चन कम्स नॉन ट्रॉमेटिक SAH cause evaluation, you want to evaluate the cause of non-traumatic SAH की NCCT पे SAH दिख रहा है, बेसल सिस्टम में है, कोई ट्रॉमा की हिस्ट्री नहीं है, now you want to evaluate the cause, then you'll do a CT angiography, then the investigation of choice becomes CT angiography. ठीक है, गोल्ड स्टैंडर्ड फॉर नॉन ट्रॉमेटिक SAH, this is DSA, digital subtraction angiography. ठीक है, good. Now let's move on to the next question. A young male presented with proptosis of right eye and there was history of road traffic accident 2 years back. 2 साल पहले हुई था trauma. The imaging reveals a homogeneous lesion in the frontal sinus. ठीक है, बोल ही दिया frontal sinus में. What is the most probable diagnosis? क्या मार्क किया आंसर? Yes, the answer is a frontal mucocele. ठीक है, this is my left frontal sinus which is normal. This is normal. And I see that the right frontal sinus is expanded and it has a homogeneous soft tissue density appearing like a fluid. So this is my frontal mucocele. ठीक है, बाकी ऑप्शन भी रूल आउट कर लेते हैं एक बार. JNA अगर होता, JNA जुवेनाइल नेजोफेरेंजियल एंजियोफाइब्रोमा, तो वो प्रोप्टोसिस नहीं कराता इनिशियली, प्लस JNA would have involved the nose. This is predominantly involving the frontal sinus. Now frontal meningioma per se is rare. meningioma ऑर्बिट में होता है, ऑप्टिक नर्व में meningioma होता है, एंड यहाँ पर ऑप्टिक नर्व अलग से कंप्रेस्ड है एक्सटर्नली. सूडो ट्यूमर ऑफ ऑर्बिट, अगेन ऑर्बिट की पैथोलॉजी होती है, हियर द पैथोलॉजी इज इन द फ्रंटल साइनस. ठीक है, so this is how my frontal mucocele looks like. Basically there is obstruction in the drainage of my frontal sinus, and so mucus and mucoid material keeps on depositing within the frontal sinus and that gets expanded. This is how my frontal sinus mucocele looks like. So mucocele is T1 and T2 bright. Remember this point, very very important point. Why? Because it is rich in proteins. Mucus protein ही एक तरह का. So mucocele rich in proteins, bright both on T1 and T2. Tell me, this first image is T1 weighted image or a T2 weighted image? What is the second image, T1 weighted image or a T2 weighted image? Good. Lot of you have answered it correctly. This is a T1 weighted image. Why? Because my white matter is white. ठीक है, this becomes my T1 weighted image. In a T2 weighted image, always the white matter is dark. This is my T2 weighted image. Per se, this is फ्लेयर इमेज है ये, क्योंकि CS है सप्रेस्ड है हमारा, और सेकेंड इंपॉर्टेंट पार्ट आपका जो विट्रेस ह्यूमर है वो भी सप्रेस्ड है, तो फ्लेयर है एक्चुअली, बट फ्लेयर ऑल्सो गिव्स T2 वेटिंग. ठीक है, तो T2 वेटिंग ही है, बट दिस इज फ्लेयर इमेज. नंबर 1 फर्स्ट इमेज इज अ T1 वेटेड इमेज, एंड हमें दिख रहा है कि लीजन T1 पर भी ब्राइट है एंड T2 पर भी ब्राइट है. सो दिस इज अ फ्रंटल म्यूकोसील अपीयरेंस. एंड दिस थर्ड इमेज, दिस इज द पोस्ट कंट्रास्ट इमेज. मैंने गैडोलिनियम दे दिया है. सी यहाँ पे वेसल्स में गैडोलिनियम दिख रहा है आपको. दिस इज माई गैडोलिनियम इमेज एंड यू सी दैट द लीजन इज नॉट सो एनहांसिंग. जितना T1 प्लेन T1 पर था उतना ही पोस्ट कंट्रास्ट पर ही है. क्यों? क्योंकि दिस इज ऑल म्यूकस, दिस विल नॉट एनहांस. दैट मीन्स दिस इज नॉट अ मेनिंजियोमा, दिस इज ऑल्सो नॉट अ नेसोफेरेंजियल एंजियोफाइब्रोमा. ट्यूमर होगा तो एनहांस करेगा, दिस इज नॉट एनहांसिंग, सो म्यूकोसील है ये. And again, this is a CT image. This is how my frontal mucocele looks like. The frontal sinus is obliterated. Look at the frontal sinus on the normal side. This is the frontal sinus which is obliterated and filled with mucus. This is my frontal mucocele. ठीक है, ये मैंने इमेज लगाई थी आप लोगों के लिए ताकि आप ऑप्टिक नर्व मेनिंजियोमा देख सको कैसा दिखता है. ठीक है, इंटेंसली इनहैंस करता है ऑप्टिक नर्व मेनिंजियोमा. ग्लायोमा पर से अगर ऑप्टिक नर्व का ग्लायोमा होगा तो वो एनहांस नहीं करता. मेनिंजियोमा एनहांसेस अ लॉट. एंड सिमिलरली नेसोफेरेंजियल एंजियोफाइब्रोमा पीछे से आएगा, नोज को पूरा इन्वॉल्व कर लेगा, ऑर्बिट फ्रंटल साइनस को नहीं इन्वॉल्व करेगा. सो दिस इज माय JNA, जुवेनाइल नेसोफेरेंजियल एंजियोफाइब्रोमा. Chalo, let's move on to the next question. I'm sure you've got this question also correct. Easy question. The following appearance in IVP is caused by. Can you see the image? Acha, you cannot see the image. Okay, wait. Tell me the diagnosis. Easy spotter है ये तो. What have you guys marked? So bilateral hydronephrosis है, cystic dilatation है terminal end of ureter का, cobra head appearance. ठीक है, also known as adder head appearance. What is the diagnosis? Ureterocele. ठीक है, इजी क्वेश्चन. यूरेट्रोसील अल्ट्रासाउंड पे भी ऐसे ही दिखता है हमें. ठीक है, डायलिटेशन ऑफ द टर्मिनल एंड्स ऑफ द यूरेटर्स. सो VUJ लेबल्ड है, वेसाइक यूरेट्रिक जंक्शन राइट एंड लेफ्ट बोथ आर डायलेटेड. सो दिस इज यूरेटरोसील. ठीक है, टेल मी व्हाट इज द डायग्नोसिस हेयर. IVP इमेज दे रखी है मैंने. साइन एंड डायग्नोसिस. And here also third ultrasound and MCU I have given. Sign and diagnosis. ठीक है, good. This is IVP. Sign is flower vase या फिर shaking hand. ठीक है, diagnosis is horseshoe. Kidney. Third, yes, sign is keyhole appearance of urethra. ठीक है, this is my dilated bladder. This is my dilated posterior urethra. And on MCU also I see that the posterior urethra is dilated, like right here. And I can see reflux also within the kidneys. This is BUR. So diagnosis is my posterior urethral wall. Good. Chalo, can someone tell me what is the diagnosis here? इन्वेस्टिगेशन में बताता हूँ. RGUP है ये, रेट्रोग्रेड यूरेटेरोपाइलोग्राम. We have cannulated the ureter and we have injected the dye. Yes, good. Diagnosis here is medullary sponge kidney. Good. Here, Sahil, between putty kidney and nephrocalcinosis I have covered in my previous classes also. Putty kidney में basically, okay, if I talk about putty kidney and nephrocalcinosis, ठीक है, putty kidney में there is cortical calcifications. The calcifications are cortical. So if this is my kidney, the calcifications in a putty kidney will be in the cortex. So they will take the shape of the kidney. Whereas in a nephrocalcinosis, the calcifications are mostly in the medulla. So उनके calcifications यहाँ पे होंगे. ठीक है, this is medullary nephrocalcinosis. एंड इसका मोस्ट इंपॉर्टेंट कॉज आपका रीनल ट्यूबुलर एसिडोसिस होता है एंड हाइपर पैराथायरॉयडिज्म. चलो नेक्स्ट, आइडेंटिफाई द स्ट्रक्चर मार्क्ड इन द फॉलोइंग एमआरआई स्कैन. ठीक है, इजी क्वेश्चन है, आई थिंक सबका ही क्वेश्चन ठीक होगा. सेरेबेलम इज द आंसर. ठीक है, अब सेरेबेलम के नाम से मुझे सू मत कर देना, आई एम जस्ट लेबलिंग द स्ट्रक्चर दैट इज मार्क्ड बाय द एरो. ठीक है, चलो फटाफट लेट्स सी द अदर स्ट्रक्चर्स ऑल्सो. सो दिस इज माई कॉर्पस कैलोसम. This is the genu, body, splenium. ठीक है, this is my midbrain, pons, medulla. This is my cerebellum. ठीक है, this is my tectum. This is my pituitary. This is the stalk of pituitary and the infundibulum. ठीक है, now next image, ये थैलेमस है मेरे दोनों, कॉर्डेट न्यूक्लियस, द प्यूटामेन, ग्लोबस पैलिडस. ठीक है, ब्लैक ब्लैक स्ट्रक्चर कौन सा है ये हमारा, दिस इज माई इंटरनल कैप्सूल. ठीक है, टू अदर स्ट्रक्चर्स आर मार्किंग हियर विद रेड. कैन समवन टेल मी व्हाट आर दीज स्ट्रक्चर्स? These are my fornix. Now the third image, this is again pons, this is middle cerebellar peduncle. This is my fourth ventricle. चलो, दैट वॉज ऑल अबाउट ब्रेन. नाउ वी कम टू मस्कुलोस्केलेटल. ठीक है, प्रीवियस क्वेश्चन है, एसीएल पीसीएल आइडेंटिफाई करने के लिए आए हुए हैं. सो पोस्टीरियर एसीएल एंड पीसीएल आर आइडेंटिफाई विद रिस्पेक्ट टू देयर अटैचमेंट ऑन द टिबिया. सो इफ देयर इज लिगामेंट इज अटैचिंग पोस्टीरियरली, दैट बिकम्स माय पीसीएल. ठीक है, पोस्टीरियर जो अटैच होगा वो पीसीएल हो जाएगा, जो एंटीरियर अटैच हो रहा होगा दैट बिकम्स माय एसीएल. ठीक है, एंड ये बोटाई अपीयरेंस जिनकी होती है, ये किस चीज की होती है, बोटाई अपीयरेंस? these are for meniscus. So if you are seeing the fibula, then these menisci are your lateral meniscus, and if you are not seeing the fibula, these are your medial meniscus. करेक्ट. नाउ ACL PCL के एक बार टीयर्स भी देख लो. सो दिस इज हाउ एन ACL टीयर लुक्स लाइक. ठीक है, एंटीरियर क्रूशिएट लिगामेंट के सारे फाइबर्स विल बी टॉर्न, यू विल नॉट बी एबल टू सी एनी फाइबर्स. एंड अनदर साइन इज साइन ऑफ अ डबल PCL साइन. कैन समवन टेल मी डबल PCL साइन इज सीन इन? एक PCL ये दिख रहा है, एक PCL ये दिख रहा है. डबल PCL साइन इज सीन इन bucket handle tear of medial meniscus. चलो, कॉर्नल एमआरआई पे हम कौन कौन से लिगामेंट्स देखेंगे? हम मीडियल एंड लैटरल लिगामेंट्स देखेंगे। तो ये मीडियल साइड है, ये लैटरल साइड है, मैं बता रहा हूँ आपको बस। ठीक है, सो ये वाला आपका मीडियल कोलैटरल लिगामेंट हो गया, ये वाला आपका लैटरल कोलैटरल लिगामेंट हो गया। जो फिबुला पे अटैच हो रहा है, दिस इज योर लैटरल कोलैटरल। जो टिबिया पे अटैच हो रहा है, दिस इज योर मीडियल कोलैटरल लिगामेंट। ठीक है, एंकल में मोस्ट कॉमनली यू आर आस्क्ड अबाउट एक्लीज टेंडन। ठीक है, दिस इज योर एक्लीज टेंडन विच अटैचेस ऑन टू द कैल्केनियम हेयर। दिस इज C is represented by calcaneum and this is your tear of your Achilles tendon. ठीक है, other bones we'll also label. This is my talus, this is calcaneum. Calcaneum joins to cuboid, talus joins to articulates with navicular. चलो, let's move on to the next question. All of the following could be the cause of the given X-ray finding except. क्या मार्क किया है इसका आंसर बताओ? अच्छा, 2 मिनट्स के लिए ना, लेट्स जस्ट टॉक अबाउट while the iPad is getting charged. Let's for 5 minutes let's talk about the strategy. अभी 10 days are left for the upcoming INI-CT. ठीक है, 10 days are left for the upcoming INI NEET PG, sorry, 10 days are left. So tell me what how are you guys reading? Revision strategy कैसी है, क्या पढ़ रहे हो आजकल? I talked about the revision strategy for the last 10 days in the first 10 minutes of the class, but I think a lot of you were not logged in on the YouTube live. So tell me, NEET PG last 10 days mein, how are you reading? So, you know what I would say that these last 10 days, you know, are your make or break time. So first of all, अगर जो टाइम अभी तक वेस्ट कर दिया उसका बिल्कुल भी दुख नहीं मनाना है कि मैंने 3 दिन मिस कर दिया और अभी तक मैंने रिविजन स्टार्ट नहीं किया है। अभी तक नहीं किया है तो कर लो, 10 days आर नॉट लेस। ठीक है, 10 days में भी आप बहुत कुछ कर सकते हो, बट अभी रिविजन 100% से स्टार्ट करना है। एंड सम ऑफ यू हु फॉलो माई यूट्यूब चैनल और अदर चैनल्स वेर आई पुट इन कंटेंट, you would know that I am a very strong proponent of these last 10-day revision strategy. ठीक है, लास्ट 10 days में क्या करना होता है ना कि सारा थ्योरी यू हैव टू रिवाइज वंस. नाउ इन दीज लास्ट 10 days, फर्स्ट ऑफ ऑल अवॉइड गिविंग GTs, avoid giving any kind of grand test in these last 10 days because grand test right now will not help you in any way. अगर उसमें रैंक अच्छी आ भी गई तो ज़रूरी नहीं है कि नीट पीजी में अच्छी रैंक आए. अगर उसमें रैंक अच्छी नहीं आ रही तो डिमोटिवेट और हो जाओगे कि यार मेरी तो रैंक ही नहीं आ रही जीटी में, हाउ विल आई डू वेल इन माई नीट पीजी. सो नो ग्रैंड टेस्ट नाउ. वट एवर ग्रैंड टेस्ट वर टू बी डन दे यू हैव ऑलरेडी गिवन देम. सेकेंड इंपॉर्टेंट पॉइंट इज अवॉइड सॉल्विंग अ लॉट ऑफ क्वेश्चंस नाउ. ठीक है, अब आपका टाइम है कि जब आप थ्योरी एक बार पूरी रिवाइज कर लो. कि जैसे ना व्हेन वी गिव USMLE एग्जाम्स or when I give any sort of competitive exams, you know what I make sure that the last 10 days I'll revise what consolidated material I have gathered over the last 1 year. You know, जब मैं अपना INI-CT NEET PG की तैयारी कर रहा था, so I made sure that I have to revise everything that I have consolidated now. Those 5-6 months of my preparation will go futile if I don't revise the theory now. बिकॉज छोटे छोटे कुछ कुछ पॉइंटर्स होंगे अभी भी आपकी थ्योरी बुक में जो कि आपके क्वेश्चंस में कवर नहीं हुए होंगे. सो आई स्ट्रांगली रिकमेंड दैट जस्ट गो थ्रू द थ्योरी वंस. नाउ हाउ डू यू रिवाइज द थ्योरी? बहुत सारे स्टूडेंट्स क्या करते हैं कि इस टाइम पर दे स्टार्ट मेमोराइजिंग थिंग्स और इवन डूइंग एक्टिव रिकॉल. नाउ एक्टिव रिकॉल अपनी जगह बहुत अच्छा है, बट एक्टिव रिकॉल के साथ द ओनली प्रॉब्लम इज दैट एक्टिव रिकॉल टेक्स अ लॉट ऑफ टाइम. ठीक है, एक्टिव रिकॉल से आप ज़्यादा कंटेंट कम टाइम में रिवाइज नहीं कर पाओगे. So eyeballing, even eyeballing right now will help because your exam is just round the corner. 10 दिन बाद ही एग्जाम आ गया है. जो आपने नोट्स बनाए हैं उनको जस्ट गो थ्रू देम. eyeballing will work. Okay. Now which notes am I talking about? So first of all depend on you totally. So अगर आपने मेन नोट्स में से हाईलाइट कर रखे हैं इंपॉर्टेंट स्टफ की टेबल्स गोले मार रखे हैं, या उसी में यू हैव कंसोलिडेटेड स्टफ इन योर मेन नोट्स, रीड दोस highlighted stuff only. If you have made revision notes as your primary revision material, do that, very good. If you have made first aid for few subjects as your revision source, do that. That is also a good source. But अभी जो आपने पढ़ रखा है वो ही पढ़ो, नया कुछ मत पढ़ो. Let's say few of your subjects are totally left, कि let's say ENT पढ़ी नहीं या डर्मा पढ़ी नहीं अभी तक, तो you can skip it. अभी नया मत पढ़ो उसको, unless that subject is very strong. Let's say कि डर्मा मेरी MBBS में strong थी, even if I just go through it in a day, I'll be able to revise everything from derma. Then only pick up a new subject. Else don't pick up a new subject now. Read whatever you have revised. Now in the first these 10 days go, let's divide these 10 days into first 5 days and the next 5 days. So first of all I want you to club a major with a minor. Okay, so we will read one major along with a minor. Now first 5 days में we'll read clinical subjects, so medicine, surgery, obs-gynae, pediatrics, PSM. And the last 5 days we'll read first and second years. In the last day, that is on 22nd, what will I read? I will read forensic, I will read anesthesia, I will read biostats formulae. ठीक है, last one day will be the most volatile stuff that I'll read. And the choti copy, if you have made a small notebook in which you have written down important forgetful stuff, you will also read that in the last day. But the clinical subjects, try to cover it in the first 4 days from now. The rest 6 days we will read first and second year along with minors. Okay, so this is my revision strategy for all of you. These last 10 days, I'm telling again, these are your make or break days. If you study well in these last 10 days, I'm sure you will get a good rank. Anyone who has any question regarding strategy can put them in the comments. So some people are saying that pharma on the last day, biochem micropath on second last, and anat physio before that. Yes, this will work. Good. Pharma very, very volatile. You can read it in the last day. अब someone is saying I only did general pharma, did not do pharma at all. यार फार्मा नहीं की तो यार फार्मा क्यों नहीं की? पहली बात, फार्मा तो बहुत इंपॉर्टेंट सब्जेक्ट है, फार्मा तो आपको करना ही है. और अगर अभी नहीं किया तो द गुड थिंग इज कि बस रिविजन नोट्स पढ़ लो फार्मा के, ठीक है. अगर और कोई छोटी कंसाइज मटेरियल है, आई एम नॉट नेमिंग दैट कंसाइज मटेरियल, अगर कोई और छोटा कंसाइज मटेरियल है वहाँ से पढ़ लो, बट एटलीस्ट रीड सम फार्मा. फर्स्ट एड में भी अच्छा दिया हुआ है फार्मा, अगर वो नहीं पढ़ना तो पीडब्ल्यू के रिवीजन नोट्स बहुत अच्छे हैं फार्माकोलॉजी के, यू कैन रीड द रिवीजन नोट्स अलॉन्ग विद द रिवीजन वीडियोस. बट जस्ट मेक श्योर कि फार्मा को आप बस एक ही दिन दो, इससे ज़्यादा दिन नहीं दे सकते आप फार्मा को. इवन इफ 60% ऑफ द फार्मा इज कवर्ड, दैट इज फाइन, बट यू हैव टू लीव फार्मा नाउ. चलो लेट्स स्टार्ट विद अवर क्लास अगेन. So is my screen visible? Yeah. So all of the following could be the cause of the given X-ray finding except. ठीक है, so what are we seeing? We are seeing air under the diaphragm. ठीक है, air under diaphragm कब होगी? Whenever there is some sort of gas within the peritoneum. So it can happen with the duodenal perforation. Yes. It can happen after laparoscopy. Yes. In laparoscopy we create an artificial pneumoperitoneum. ठीक है, and that is why some of the pneumoperitoneum can remain in the immediate post-op period. So post laparoscopy also you can see air under the diaphragm. Now Chilaiditi syndrome is pseudo-pneumoperitoneum. Pseudo-pneumoperitoneum. What happens here is that the hepatic flexure gets interposed between the right dome of diaphragm and the liver, and that gives an appearance of air under the diaphragm. We know hepatic flexure, colon has air, so that can abnormally give an appearance of air under the diaphragm. But acute intestinal obstruction will never have air under the diaphragm unless it is perforated. So the question has to specifically mention perforated acute intestinal obstruction. ठीक है ना. तो acute intestinal obstruction will have air fluid levels. Now, Mitomycin is asking, sir, biochemistry कितनी important है INICT and NEET PG के लिए? यार biochemistry again very very important यार. You can't afford to skip biochemistry. Biochemistry, the good thing about biochemistry is that इसका syllabus limited है. So अगर आपने अभी तक अच्छे से नहीं किया biochemistry and you want a concise resource for biochemistry, first aid again is a very very good option. बाकी रिविजन नोट्स जो पीडब्ल्यू के हैं, देर ऑल्सो वेरी नाइस फॉर बायोकेमिस्ट्री. जम्बुलकर सर ने बहुत अच्छे रिविजन नोट्स बनाए हैं. यू कैन कंसिडर रिविजन नोट, बट मेन नोट्स नहीं पढ़ने हैं. मेन नोट पढ़ने का टाइम चला गया है. एंड जस्ट मेक श्योर अगर आप अपना कोई लैग हुआ वाला सब्जेक्ट कवर कर रहे हो ना अभी, तो जस्ट गिव 1 डे टू इट, उससे ज़्यादा नहीं देना है. आई हैव डन सर्जरी बट अभी आई एम डूइंग फॉर लास्ट 2 टाइम्स एंड येस माई ENT एनाट इज वेरी बैड. हाउ टू अप्रोच? ENT खराब है, छोड़ दो ENT को. एनाटमी अगर खराब है, हेड एंड नेक पढ़ लो, न्यूरो पढ़ लो, एम्ब्रियोलॉजी पढ़ लो, बस. दैट इज हिस्टोलॉजी ऑल्सो. हिस्टोलॉजी टेक्स 1 to 2 hours ओनली. न्यूरो, head and neck and embryology, only these 3 things you read in anatomy. And again, एक दिन से ज़्यादा अभी नहीं दे सकते. Medicine didn't do at all sir, should I do PYQs or just leave it? Just leave it. अगर नहीं करी मेडिसिन, just leave it. ठीक है प्रांजल, आई थिंक यू तुम्हारा क्वेश्चन सॉल्व हो गया. सर एनाटमी फीलिंग वेरी डीमोटिवेटेड. यार एनाटमी बहुत गंदा सब्जेक्ट है. मतलब एनाटमी वॉज माई स्ट्रॉन्ग सब्जेक्ट, बट आई नो दैट बहुत सारे स्टूडेंट्स का वीक सब्जेक्ट होता है. सो द ओनली थिंग दैट यू कैन डू इन एनाटमी नाउ इज टू रीड सेलेक्टिवली. और सेलेक्टिवली क्या पढ़ सकते हो अभी? हेड एंड नेक पढ़ो, न्यूरो एनाटमी पढ़ो और एम्ब्रियोलॉजी पढ़ो, बस. Sir, I have done surgery but didn't revise since 2 months, but I have done 2 to 3 times. What should I do? ठीक है, if you have from whichever source you have revived surgery, that is fine. ठीक है, अब चेंज मत करो सोर्स. जस्ट बिलीव इन वट एवर सोर्स यू हैव रेड एंड दैट इज फाइन. ठीक है, ये मत सोचो कि इज दिस इनफ, दैट इज इनफ नाउ. ठीक है, अब नया कुछ नहीं पढ़ना. बाकी सब्जेक्ट्स में वी विल कॉम्पनसेट. हाउ टू रिवाइज एनाटमी? सर यार एनाटमी पढ़ने के लिए यही है, सिलेक्टिव रीडिंग ही है. इफ यू हैव ऑलरेडी डन एनाटमी वंस, a good thing to do is to revise with the help of an atlas. So I've already put in a video that how I revised anatomy. I used a Netter's atlas. उसमें images देख के relevant theory I used to add there only and revise it. So you can do that. Sir, ENT and ophtha I just have read it but not revised. यार lately तो ENT ophtha से questions आ रहे हैं. If you have to choose one between ENT and ophtha, choose ophtha because ophtha की ज़्यादा weightage है ENT as compared to ENT. ENT के कुछ क्वेश्चन यू विल गेट राइट फ्रॉम रेडियोलॉजी, बाकी क्वेश्चन छोड़ देना. ठीक है. व्हाट अबाउट ऑफ्था सबका वीक है. सर नेक्स्ट एग्जाम अगर पोस्ट इंटर्न्स को देना पड़े तो स्ट्रैटेजी के लिए 1 to 2 सब्जेक्ट्स में फोकस कर रहे हैं या फाइनल ईयर सब्जेक्ट्स ऑफ एमसी लेगा पेपर? अगर नेक्स्ट एग्जाम होगा ना तो तब देखेंगे. नेक्स्ट एग्जाम की अभी हम टेंशन नहीं ले सकते. थोड़ा उसका गाइडलाइंस आने दो, थोड़ा फॉर्मुलेट होने दो वो. Let it become more streamlined, then we'll talk about the strategy for next. PSM, what to do? PSM very very important. PSM के रैपिड रिविजन उठाओ. ठीक है, सारे टीचर्स ने PSM छोटा क्रिस्पी पढ़ाया है, रैपिड रिविजन पढ़ डालो. रट्टे वाला सब्जेक्ट है PSM. बस बायोस्टैट्स हैं थोड़े लॉजिकल, बाकी तो पूरा रट्टा है. Sir, I have finished somewhat reading once and still my score is around 130. Not getting motivation to do and push. Don't know what to do. यार अगर GT छोड़ दो, अब GT में 130 आ गए कोई बात नहीं. अभी जो आपने रिविजन करने के लिए रिविजन नोट्स बना रखे हैं ना अपने, बस उन्हीं को पढ़ना है. ओनली रिविजन नोट्स, नथिंग एल्स. चलो, लेट्स मूव ऑन टू दिस क्वेश्चन. सो व्हाट इज द इन्वेस्टिगेशन ऑफ चॉइस? वी हैव ऑलरेडी कवर्ड. इट इज CECT. ठीक है, इन्वेस्टिगेशन ऑफ चॉइस इज CECT. Now, what is the rule of 3, 6 and 9 in cases of intestinal obstruction? So 369 basically tells that what is the cutoff of a bowel diameter to call it a dilated bowel loop for intestinal obstruction. So for small bowel, whenever the small bowel diameter is more than 3 centimeter, or for large bowel it is more than 6 centimeter, and for cecum it is more than 9 centimeter, then we call them dilated. ठीक है? And an important sign of a intestinal obstruction is your small bowel feces sign. Small bowel feces sign. What is the small bowel feces sign? So normally small bowel में air नहीं होती है, air colon में होती है. Colon has air producing bacteria, so colon में air होती है. Small bowel intestine में you will never see air. But if you see dilated small bowel loop with these speckled air and they are appearing like a colon, but इनमें hostre वगैरह कुछ नहीं है, then this is what is known as a small bowel feces sign, and it is a sign of intestinal obstruction. And it basically tells that the contents in the small bowel have been lying for such a long time that they have started to undergo fermentation and produce gas. So this small bowel feces sign is a sign of subacute intestinal obstruction. ठीक है, SAIU भी बोलते हैं इसको. ठीक है. नाउ एक्सरे में क्या दिख रहा है हमें? एक्सरे में वी आर सीइंग एयर फ्लूइड लेवल्स. Bharat is asking very good question. Sir, why is CCT preferred over NCCT in abdomen in obstruction? So remember CCT के साथ एडवांटेज क्या है कि इसमें ना हमें बाउल वॉल भी अच्छे से दिख जाती है. वी आर एबल टू अप्रिशिएट द बाउल वॉल बिकॉज इट एनहांसेस. whenever we give contrast it enhances. So CCT के साथ we can see the level of obstruction and the cause of obstruction also. ठीक है, कि कोई स्ट्रिक्चर तो नहीं है. अल्सरेटिव कोलाइटिस या क्रॉन्स डिजीज हो सकता है, टीबी हो सकता है एज अ कॉज ऑफ ऑब्स्ट्रक्शन, उसमें स्ट्रिक्चर एनहांस करेगा. क्रॉन्स डिजीज में हमें कूम साइन मिलेगा. अगर कोई ट्यूमर ऑब्स्ट्रक्ट कर रहा है तो ट्यूमर एनहांस करेगा. So to know the cause and the level of obstruction, CCT is better than a non-contrast CT. Now next question, identify the sign shown in the image. So easy sign. ठीक है, diagnosis बताओ क्या है and sign क्या है? So sign is sawtooth sign. Diagnosis is diverticulosis. ठीक है, diverticulitis नहीं बोलना है. इन्वेस्टिगेशन कौन सी है? बेरियम अनीमा. ठीक है, चलो गुड. एप्पल कोर साइन किस में मिलता है? दिस इज एप्पल कोर साइन. दिस इज सीन इन CA colon. दिस इज माय corkscrew appearance of esophagus. दिस इज सीन इन diffuse esophageal spasm और DES. DES के साथ क्वेश्चन में क्या बज़वर्ड होगा? डिस्फेजिया विद चेस्ट पेन. डिस्फेजिया विद चेस्ट पेन, diffuse esophageal spasm. बेरियम swallow पर you'll get corkscrew appearance. थर्ड साइन इज स्ट्रिंग साइन. ठीक है, बेरियम BMFT दे रखा है, ये बेरियम मील फॉलो थ्रू. एंड स्ट्रिंग साइन दे रखा है, स्ट्रिंग साइन ऑफ कंटूर. किस में मिलता है? डायग्नोसिस इलियोसिकल TB. ठीक है, कभी कभी स्ट्रिंग साइन हमें स्टमक में भी मिलता है. स्ट्रिंग साइन इन स्टमक. तो ये किस में मिलता है हमें? ये पाइलोरिक स्टेनोसिस में मिलता है. इन्फेंटाइल हाइपरट्रोफिक पाइलोरिक स्टेनोसिस. चलो नेक्स्ट क्वेश्चन. हिस्ट्री ऑफ ट्रॉमा, लिम्ब शॉर्टनिंग वाज नोटेड, नर्व कॉमनली इंजर्ड इन दिस इंजरी. ठीक है, सो हिप डिसलोकेशन है. हिप डिसलोकेशन पोस्टीरियरली ज्यादा कॉमन होता है. शोल्डर डिसलोकेशन एंटीरियरली इज मोर कॉमन. तो पोस्टीरियर कौन सा नर्व होती है हमारी? शियाटिक नर्व. सो हिप डिसलोकेशन में मोस्ट कॉमनली नर्व इंजर्ड इज अ शियाटिक नर्व. ठीक है, hip dislocation you will read in detail in your orthopedics. So this is just a question that I've discussed from orthopedics. Now next question. Postmenopausal female with intermittent pelvic pain on OPD. X-ray was done. What is the likely diagnosis? ठीक है, कितना अच्छा क्वेश्चन है. So यहाँ पर हमें ये calcified mass दिख रहा है, off midline है. This is not in the center. It is off midline and it has this speckled calcification within. ठीक है, this is calcified fibroid. Now bladder calculus कैसा होता है? Bladder calculus has a lamellated appearance. ठीक है, second I'll show you how bladder calculus looks like. Ovarian carcinoma, first of all x-ray पे you cannot see ovarian carcinoma, calcifications भी नहीं होते हैं ovarian carcinoma में. You see it either on ultrasound or an MRI. Kidney calculus kidney में होगा, यहाँ पे तो आपका pelvis दे रखा है, so kidney is ruled out. So this is calcified fibroid. This is how my bladder calculus looks like. So this has a lamellated appearance. Bladder calculus. Why? Because there is a long standing stasis. There is stasis of urine in the urinary bladder, and that forms layers of calcification one after the other, giving it a lamellated appearance. Now this can either be solitary or these can be multiple. अगर multiple होंगे तो वहाँ भी lamellated appearance ही मिलेगी. देखो इसका, as we can see in this image. Now a type of bladder calculus that have these pointy edges. ठीक है, these are jackstone calculi. Jackstone calculi are nothing but bladder calculi which have pointy edges. ठीक है, and another X-ray potential future question. This is an image. अगर आपको कोई ऐसा patient की X-ray मिले and the history is given कि there is history of the patient is from Afghanistan and like it is suggesting some trafficking of any drugs, caught by the police, patient presented to the hospital with sudden onset shock, hypotension, frothing from mouth, and you see this X-ray in which you can see these tubular structures within the bowel. Okay, this is my body packer. Good. This is body packer. Chalo, next question. Person presents after 10 weeks with acute pancreatitis. What is the diagnosis? Take a easy question. Pancreatitis history may given, and you see a large collection which is homogeneous. Buzzword is a homogeneous collection. एक जैसा दिख रहा है. क्या आंसर होगा? Pseudocyst. Good. A. Liver abscess liver में होगी. गैस्ट्रिक आउटलेट ऑब्स्ट्रक्शन में स्टमक डायलेटेड होगा, बट पैनक्रियास की कोई हिस्ट्री नहीं दे रखी होगी. एक्यूट पैनक्रेटाइटिस में सूडोसिस्ट नहीं बनती. एक्यूट पैनक्रेटाइटिस का कॉम्प्लिकेशन है सूडोसिस्ट. एंड अनदर पॉइंटर दैट इट इज अ सूडोसिस्ट दैट इट इज कैप्सुलेटेड. इट इज अ कैप्सुलेटेड, सो इट इज होमोजेनस एंड कैप्सुलेटेड. Now let's quickly revise the various collections that form in acute pancreatitis. So if there is no necrosis, so first of all, main aim for doing a CT scan is to see necrosis. Investigation of choice for pancreatitis, it is CECT. And CT pe what do we want to see? We want to see necrosis. So if there is necrosis present or necrosis absent. So if there is necrosis present, then it can either be acute peripancreatic fluid collection or it can either be a pseudocyst. So acute peripancreatic fluid collection is less than 4 weeks and pseudocyst is formed after 4 weeks of acute pancreatitis. So acute peripancreatic fluid collection will have only small amount of fluid and no wall, whereas a pseudocyst will have a wall. And both of them will not have any necrosis of the pancreas. So you see that there is no necrosis here. Pancreas is normal. And here also there is no necrosis. Whereas if there is necrosis present, sorry, this was absent. If there was necrosis present, then the type of collections that are formed are acute necrotic collections and a walled off necrosis. They also have a cutoff of less than 4 week and more than 4 week. ठीक है, so walled off necrosis में wall होगी but हेट्रोजिनस होगा, थोड़े ब्लैक ब्लैक एरियाज मिल जाएंगे आपको फैट सेपोनिफिकेशन के. Acute necrotic collection में there will be no wall, but you can see that this is the area of necrosis. This is how my pancreatic necrosis looks like. This is my acute necrotic collection. Investigation of choice is CCT. Best time to do a CT scan is day 3 to day 5. ठीक है, day 3 to day 5. Best sign of infected collection on CT scan is presence of air within the collection. ठीक है, so this is a brief capsule about imaging in acute pancreatitis. Now, फटाफट, a 35-year-old female presents with dysphagia, regurgitation and weight loss. What is the likely diagnosis? So, in easy question, tell me the sign and the diagnosis. ठीक है, eclasia cardia, bird beak appearance. ठीक है, eclasia cardia is very very important from your NEET PG point of view. सर्जरी से अच्छे से पढ़ना है eclasia cardia को. Dysphagia, regurgitation, weight loss, typical findings. Dysphagia 2, liquids more than solids, upper GI endoscopy पे cave like esophagus. Investigation of choice, gold standard manometry. Investigation of choice, barium swallow. ठीक है, manometry पे Chicago classification, management, everything you have to remember for eclasia cardia. Very very important pathology as far as your NEET PG is concerned. Now, next question. A newborn baby presented with respiratory distress. Diagnosis. What is the diagnosis based on the image? So again, an easy question. What have you guys marked? Yes, the answer is congenital diaphragmatic hernia. You can see that the heart and the mediastinum is pushed to the right side. ठीक है ना? This is the trachea, this is the NG tube, this is the trachea with the ET tube. All has been pushed to the right side, and you can see that the bowel loops have come into the thorax. This is congenital diaphragmatic hernia. Bag and mask ventilation is contraindicated. Most common site is posterior diaphragm defect. What do we call it? Bochdelic hernia. ठीक है. Yes, you'll have a scaphoid abdomen because all the bowel loops have come into the thorax. If there is an anterior hernia, what is its name? Its name is Morgagni's. Morgagni's hernia is anterior diaphragmatic hernia. Chalo. So this is how my hiatal hernia looks like. ठीक है, retrocardiac, you will see air fluid levels. This like this. This is hiatal hernia. Heart के पीछे there is a hernia and there is air fluid levels. ठीक है. Now this is my respiratory distress syndrome, RDS, hyaline membrane disease. ठीक है, white out lung. ठीक है, and this is my TTN, transient tachypnea of newborn. What is the name of the sign? There is fluid in interlobar fissure. ठीक है, you see this is the fluid in the interlobar fissure. Very very characteristic of transient tachypnea of newborn. So the patient will be, the neonate will be distressed at birth, tachypnic at birth. And you get an X-ray, you will see the hazy chest X-ray, and you will consider that maybe this is a hyaline membrane disease, but it will have fluid in the interlobar fissure, and the treatment is conservative treatment. And a repeat chest X-ray will show that the fluid in the lungs have cleared. Okay? This is what is transient tachypnea of newborn. Now, just remember the name of a sign. I'm giving you a new sign now. in TTN, a specific sign is known as double lung point. This is a specific sign of transient tachypnea of newborn. Yes, TTN mostly happens in term baby. HMD happens in preterm babies. So next question, easy question, asked in AIMS. 19-year-old male with high-grade fever and productive cough. What is the likely diagnosis? ठीक है, consolidation है, basically asking which lobe is the consolidation. So here my right heart border is obscured. There is silhouetting of the right heart border. So this is RML, right middle lobe consolidation. Let's quickly revise. How do we identify different lobes involved in consolidation and collapse? So if my right heart border is visible, but my right hemidiaphragm is obscured, so the pathology is in the right lower lobe. If my paratracheal stripe is obscured, then it is in the right upper lobe. Similarly, if my right heart border is obscured, the pathology is in the RML. And on the left side, if the left heart border is obscured, it is the lingula segment of the left upper lobe. And finally, if the aortic knuckle is obscured, the pathology is in the left upper lobe. And if the left hemidiaphragm is obscured, it is in the left lower lobe. Okay, so easy, very commonly asked. I'm sure all of you have gotten this question correct. Previous year question. Now I'm sure all of you have gotten this question also correct. A 35-year-old male presented with pain and swelling around the wrist joint. There is no history of injury. X-ray is shown below. Tell me what is the diagnosis that you have guys marked. Easy question. ठीक है, 35-year-old, so adult, after skeletal maturity, lytic lesion, epiphysis, right? And reaching till the articular surface. All the buzzwords. ठीक है, diagnosis is an easy giant cell tumor. ठीक है. Now, similar looking image, but in a skeletally immature child, you see that the growth plate is open. So it must be around 15-year-old boy or a girl. And the lesion is in the metaphysis. ठीक है. What have you for this? What will be the answer? The diagnosis here will be aneurysmal bone cyst. Yes, good. Similarly, look at this second image. In this you can see that there is a metaphyseal lesion, again a lytic metaphyseal lesion, and there is a broken fragment which is there. So fallen fragment sign, name of the sign is fallen fragment sign, site is metaphysis, and the diagnosis is a simple bone cyst or a unicameral bone cyst. Similarly, tell me the diagnosis of these three and fourth image. Third image, small bones of hands and feet. Small bones of hand. Diagnosis, enchondroma. Two syndromes associated with it, Olliers and Maffucci's. In Olliers, you get only enchondromas. In Maffucci's, you get enchondromas plus soft tissues hemangiomas. ठीक है. Similarly, tell me this fourth image, very spotter. 20-year-old comes to you with severe night pain not relieved on NSAIDs, and you get a CT scan, you see a lytic lesion with exuberant surrounding sclerosis. What is the diagnosis here? This is osteoid osteoma. Good. Osteoid osteoma happens in young patients, occurs in diaphysis, and the treatment is an RF ablation, radio frequency ablation of this nidus. ठीक है. Now let's move on to the next question quickly. The following appearance as shown below is present in. ठीक है. So easy question. These are cannonball metastasis. ठीक है, bilaterally randomly distributed throughout the lungs, big ball like masses, these are metastases. TB will have miliary nodules if they are bilateral and symmetrical, and they are very small. If it is unilateral, it will have predominance for the upper lobe. Pulmonary hematoma will have popcorn calcification. And bronchogenic CA will be central, and it will be usually single unless it is metastasized. The answer here will be METS. So next question, 30-year-old patient has a history of a car accident 2 years ago and is experiencing pain and swelling in the same area. X-ray shown, what is the most likely diagnosis? So you see that there is sclerosis of the bones. This is an AP and a lateral view. So these are nothing but the same bones. And on this image, you can see the sequestrum here. This is a sequestrum and surrounding sclerosis. This is my involucrum. So the answer here is chronic osteomyelitis. Good. Okay. Similar question asked in NICT this year. Chronic osteomyelitis, a CT scan was given instead of an X-ray. Again, findings are same. You can see a sequestrum and you can see an involucrum. Okay. Now look at this X-ray. So tell me this is a case of an osteosarcoma. Okay, sunburst periosteal reaction. Now this X-ray, you see that some periosteal reaction is there and there is erosion of this bone. Now a typical history is very relevant in such scenario. So let's say it is a 5-year-old boy, X-ray of a 5-year-old boy who presents with fever, redness of the limb, and this is an X-ray which is given. So we see that there is a diaphysis involvement, there is no sequestrum and involucrum, and there is some Codman triangle that is present here in a 5-year-old. So you will suspect an Ewing's sarcoma in such a scenario. Okay. Similarly, if there is a punched out lesion in the bone, in the diaphysis, you will think of METS and multiple myeloma. Now let's move on to the next question. A 25-year-old male injured his left shoulder when he was playing rugby. So currently he feels pain in his left shoulder and is unable to move his arm. X-ray of the shoulder was done and is given below. What does it depict? Okay, so tell me, what have you guys marked? This is the pathology. I'm marking the pathology here also. What have you guys marked? So a lot of you have marked Pancreatitis lesion. Why? Because the question has given you shoulder dislocation, pain in the shoulder, and you are saying that it is a shoulder dislocation. And whenever shoulder dislocation is given, so we mark bony Pancreatitis. No, that is not how you attempt. So you see that the lesion is on the humerus. It is on the posterolateral superior aspect of the humerus. Pancreatitis is on the glenoid. It is in the scapula. This is the location of your Pancreatitis lesion. The yellow pointer is pointing towards the Hill-Sachs lesion. Answer here is Hill-Sachs. Now, what is a bony Pancreatitis? What is a Hill-Sachs? So remember, whenever a shoulder dislocates, so this is my normal shoulder. So normal shoulder has a humeral head which articulates with the scapula, glenoid scapula. Now, most common shoulder dislocation is anterior dislocation. This we know. Now, whenever the shoulder will dislocate anteriorly, the anterior part of the glenoid will hit the posterior part of the humerus. right? This will what will happen. So the injuries will be where? The injuries will be in the anterior part of the glenoid and the posterior part of the humerus. So the posterior defect in the humerus is known as your Hill-Sachs lesion, and the anterior bony injury is known as the Bankart lesion. So Bankart is in the glenoid and Hill-Sachs is there in the humerus posterior superior aspect. So answer there was a Hill-Sachs lesion. And again, see, this is an MRI arthrogram, again MR arthrogram of the shoulder. This is the Hill-Sachs lesion which has been marked, and this is the Bankart lesion. Okay. Now let's see the next image. So we are almost completing in like next 10 minutes. Okay, so tell me the diagnosis quickly. What have you guys marked as the answer? The X-ray plain radiograph was shown below of a 19-year-old male who was brought to the orthopedics OPD with complaints of localized pain at the right lower femur. What is the likely diagnosis? What have you guys marked? Can you see my screen? Okay. Wait. Okay, first of all, tell me, while I connect the screen, first of all, tell me, is it a benign looking lesion or a malignant looking lesion? Tell me these two things. Is it a benign looking lesion or a malignant looking lesion? Yes, so it is a malignant looking lesion. Why malignant? Because there is cortical breach. The bony cortex is breached. There is cortical breach. The bony cortex is breached here. So this is a malignant looking lesion. So my fibrous cortical defect and giant cell tumor are out. Okay. Now tell me, even if you do not know how to read what tumor is it particularly, you're talking about a 19-year-old male and you're left with chondrosarcoma and osteosarcoma. So what will be the answer? What have you guys marked? It will be osteosarcoma. It will be osteosarcoma, right? And that is what is the answer. Now some of you will say, sir, there is no Codman's triangle, there is no sunburst periosteal reaction, it is not a sclerotic looking tumor. So 25% of osteosarcoma can be purely lytic. Okay. And what is this variety of osteosarcoma that is purely lytic? This is telangiectatic osteosarcoma. So even if you do not know what is telangiectatic osteosarcoma, by ruling out options you can get to the correct answer, and that is that is how you have to attempt your PG entrance paper. It is an exam of exclusion of options. You do not need to know all the 200 questions, so you rule out options and get to the correct answer. That is how you approach this. Now bimodal age of osteosarcoma होती है, बट 19-year-old में कॉन्ड्रो तो नहीं होता है. ठीक है, अगर ये 50-year-old होता आप तब बोल सकते थे सर ऑस्टियो भी हो सकता है, कॉन्ड्रो भी हो सकता है, बायमोडल होता है ऑस्टियो का, बट 19-year-old में कॉन्ड्रो सार्कोमा नहीं होगा. ठीक है, आई थिंक वी आर क्लियर ऑन दैट. Now this is how a typical osteosarcoma looks like. This is how my chondrosarcoma looks like. Chondrosarcoma. So first of all, chondrosarcoma has ring and arc calcification. So it is a calcified tumor. It has ring and arc calcification. So see this image. these arc, ring, these type of calcification, these cloud-like calcification, these are hallmark of chondrosarcoma. Whereas osteosarcoma has usually a sunburst periosteal reaction that we have just read. Now, I am talking about a telangiectatic variety of osteosarcoma that is purely lytic, and for that an MRI is done which shows my blood fluid levels. Just remember, in telangiectatic osteosarcoma, this is purely lytic and it shows blood fluid levels on MRI. So Sahana is asking, why can't it be chondrosarcoma? So I've already told you chondrosarcoma is sclerotic tumor. It has ring and arc type of calcification, number one. And second, it doesn't happen in a 19-year-old patient. It happens in elderly, 45, 50, 55, 60-year-olds, not in a 19-year-old. Age is very, very important as far as your diagnosis of bone tumors is concerned. Now, this is how a typical fibrous cortical defect looks like. It is a metaphyseal lesion, metaphyseal to diaphyseal, sometimes dia also, and it is a cortical based lesion. Okay, it is limited to the bony cortex, and this is a do not touch lesion. That is, you do not need to do any biopsy. This is a diagnosis on X-ray, and just a follow-up is required, nothing else. Okay. Now let's discuss, we'll come to this question in a bit. This is a little lengthier question. We'll discuss the remaining two questions first. So what is the diagnosis in a 28-year-old lady whose HSG image is shown below? So I think all of you must have gotten this this question correct. You see that only one uterine horn is visible and one side fallopian tube is opacified. Okay, one side fallopian tube opacified means only one horn. That means it is a unicornuate uterus. Okay, how will the remaining type of uteri appear? So this is my unicornuate uterus. Yes, the answer is C. There are in the second image, B image, you have two cervices, two uterine horns, two fallopian tubes. So this is diadelphus. The third image, there is a single uterus but two separate fallopian tubes. This is bicornuate. Third, there are two cavities, but they are incompletely separated. Also, the uterine fundi, the uterine horns are not wide apart. So this is my septate uterus. And finally, this is an arcuate uterus in which there is no division of the cavity per se, just an indentation of the fundus. And finally, a T-shaped uterus, test related. These will be covered in detail in your gynae, and this was just a spotter based session for your Mullerian anomalies. Now someone is asking how to differentiate between fibrous cortical defect and osteoid osteoma. Okay, a very, very good question. First of all, fibrous cortical defect is asymptomatic. Okay, it is an incidental finding. And second, in a fibrous cortical defect, you do not see any exuberant sclerosis. Yes, there is some sclerosis, but it is very less. In an osteoid osteoma, this is the amount of sclerosis that would have happened. It is very, very exuberant, and the patient has a lot of pain. These two are the differentiating pointers between a fibrous cortical defect and an osteoid osteoma. Okay, so we move on to the last question now. A 38-year-old male gymnast was brought to the emergency hospital after damaging his perineal area during practice. He has difficulty to urinate and an urological examination reveals blood at the tip of urethral meatus. Take a difficulty to urinate, micturate, blood at meatus, perineal hematoma. What are we talking about clinically? This is a urethral injury. Okay, Urethral injury, investigation of choice, RGU, retrograde urethrogram. Okay, so retrograde urethrogram was done, and what does it show? This is my RGU ka catheter, and through this I am putting a dye, and there is I am seeing extravasation of contrast from the urethra. So this is a urethral injury. Now, which part of the urethra is involved? Okay, so tell me which part of the urethra is involved. What have you guys marked? So this is my bladder. This is my prostatic urethra. This is my bulbar urethra. And this is my penile urethra. So where is the injury? It is in the membranous urethra. Most common site of urethral injury is the bulbomembranous junction. Bulbomembranous junction. And the investigation of choice for a urethral injury is RGU. No, the answer is not bulbar urethra. Bulbar urethra is this, you know, a lot of students have difficulty in identifying bulbar urethra. Bulbar urethra is this thoda sa dilated part of the urethra. That is what is my bulbar urethra. ठीक है, उसके ऊपर very small part just at the level of urogenital diaphragm, that is what is my membranous urethra. Now a bonus tip for you, what is the name of classification? Can anyone tell me the name of classification for urethral injuries? It is Goldman classification. Now somebody is asking a very important good question, that can membranous injury lead to perineal hematoma? So like if you look at this image, and I didn't want to touch this part, if you look at this image, this injury is extending till the bulbous urethra. Why am I saying that? Because radiologically on an X-ray, how do you see the level of urogenital diaphragm? It is at the level of the inferior border of obturator foramen. Okay, the inferior border of the obturator foramen corresponds to urogenital diaphragm on X-ray. Now, if you carefully look, this injury is extending till the proximal part of the bulbar urethra also, and that probably is the reason of a perineal hematoma in such a scenario. But if you're asked to choose between bulbar and membranous urethra, the better answer here would be a membranous urethra. Yes, although you guys are right that membranous urethra or posterior urethral injuries are more commonly with pelvic fractures, whereas anterior urethral injury are more common with straddle injuries. But as a image-based question, if you are asked to choose between membranous and bulbar urethra, better answer would be a membranous urethra in this case. Okay, this is again an example. This is an example of an anterior urethral injury. Okay, your penile urethra is getting injured, and this is an example of your again a membranobulbar injury. Both the membranous and bulbar urethra are injured here. Name of the classification we have already covered, Goldman classification. Okay, so one question is left, and this was a little tough question. So can you guys tell me what have you guys marked as the answer for this question? समझ आया ये question कि नहीं आया? 50-year-old man, a chronic alcoholic who tested positive for Hep B, arrived at GI department with major complaints of abdominal distension, jaundice. Laboratory investigation revealed functions LFT elevated and bilirubin also elevated. A radiographer होगा, a clinician obtained a triple phase CT which includes a late arterial, venous and a delayed phase. ठीक है. So what is which of the following is correct? चलो ठीक है. In venous phase there will be a pacification of portal vein and not the hepatic vein and IVC. In late arterial there will be pacification of arteries only, not the portal vein or hepatic vein. In delayed, the contrast can be seen in the renal, pelvic ileal system and the ureters, and all of the above are true. So the correct answer is C. The correct answer to this question is C. Now let's talk about what are the various phases of a triphasic CT. Okay, little tough question at MBBS level, but you know I have to keep some questions tough so that you guys don't get 100 out of 100. Okay, so what are the phases of triphasic CT? So normally we take a early arterial phase, a late arterial, a venous phase, and a delayed phase. Okay. Now, in an early arterial phase, first of all, it is taken 15 seconds after the start of contrast injection. Late arterial is taken 30 to 40 seconds after start of contrast injection. Venous phase is taken 60 to 80 seconds later, and delayed phase is 3 minutes to 5 minutes after start of contrast injection. Now, why are these different phases done? So in an early arterial phase, the contrast will only be in the aorta and large veins like IVC, because the contrast is going through the IVC, through the veins. Okay? So in the early arterial phase, the contrast will be only in arteries. Okay? So why do we do an early arterial phase? To see arterial pathologies like extravasation, contrast extravasation, any आर्टीरियल इंजरी हो गई है कोई, ठीक है, या लेट्स से सूडो एन्यूरिज्म. For any arterial pathologies, we do an early arterial phase. Now, in a late arterial phase, what happens at around 30 to 40 seconds, the contrast goes into the portal vein also. So, in a late arterial phase, the portal veins are opacified, but my hepatic veins are not opacified. So this is an example of my late arterial phase. Late arterial. Here the portal veins, these are my portal venous radicals. They are opacified, but my hepatic veins, they are not opacified. In my venous phase, what happens? The hepatic veins, portal veins, both are opacified. So this is how my venous phase looks. These are my hepatic veins, which are very well opacified. So this becomes my venous phase. This was my late arterial, and this is early arterial. And in the delayed phase at 3 minutes to 5 minutes, what happens? All the contrast now excretes through the kidney. So at delayed 3 to 5 minutes, my pelvic ileal system and the ureters are opacified. Okay? So the correct answer here was D, that in delayed phase the contrast can be seen in renal pelvis and ureters. In late arterial phase, the contrast will be seen in arteries and portal vein, but not hepatic vein. Okay, so this was wrong because it was mentioning not the portal vein. In A venous phase, there will be opacification of portal vein, not the hepatic veins. No, the hepatic veins will also be opacified in the venous phase. Okay, so this was the answer to this question, triple phase CT. And why do we do a triple phase CT? Triple phase CT is done for liver masses. Okay, characterization of liver masses. Why? Because liver has dual supply. Hepatic artery भी liver को supply करती है, portal vein भी liver को supply करती है. That is why we do a triphasic CT. Okay, so two important tumors you remember. One is a hemangioma In hemangioma, what is the typical appearance of hemangioma on a triphasic CT? That on an arterial phase, there will be a peripheral nodular enhancement, which on venous and delayed phase will show gradual filling in. So hemangioma has nodular, discontinuous, peripheral, arterial enhancement with progressive filling in. Why filling in? Because hemangioma is nothing but blood spaces. So as the time passes, 3 minutes ho gaye, ab hemangioma will completely opacify. That is why nodular discontinuous enhancement with peripheral with progressive filling in. Whereas if you consider HCC are typically enhancing on arterial phase. So they are hyper enhancing on arterial phase, and they show a washout on a venous or delayed phase. That is, they become hypodense as compared to the normal liver parenchyma. So for HCC, what will we write? We'll write arterial phase hyper enhancement with venous washout. Okay, washout is a very hallmark of malignancy in liver. Okay, if your tumor is showing washout, be very careful that it might be HCC. Now tell me, just quickly tell me, what is the reporting system used in liver, reporting system for liver masses? It is LIRAT. ठीक है, and इसमें LR5 is definite HCC. If on imaging you are getting a LR5 lesion, it is definite HCC and no need for biopsy. Very important. LR5 lesions do not need biopsy. They are definitely HCC and directly treatment can be done for LR5 lesions. So that was all for today's test and discussion. You can find the PDF to this lecture. We will upload it on our Telegram channel. If some of you have not joined the Telegram channel, you can scan the QR code and join the Telegram channel. The PDF of today's class will be uploaded there. So that's all from my side. If you have any questions, you can put them in the chat box. Thank you all for attending. It was really nice teaching you, talking to you, and I hope you like the class. And I'll see you in the next class. And all the very best for your upcoming NEET PG. I am sure you guys will do well. Just remember, these last 10 days are your make or break. 10 to 12 hours per day is a minimum study now. Just revise entire theory. Stop giving grand tests. Okay? On the exam, I would say that make a good strategy, since NEET PG will also now be in blocks. So you have 42 minutes for a 40 question block, which is very good. So try to finish 40 questions in 35 minutes. And for the remaining 7 minutes, keep them as revision for that particular block. ठीक है, ब्लॉक का तुम्हें एडवांटेज ही होगा. ठीक है, डोंट वरी अबाउट क्वेश्चंस कमिंग इन ब्लॉक, इट विल ओनली बी हेल्पफुल फॉर यू. ठीक है, and just make sure that attempt more than 190 plus minimum. If you're able to rule out at least one option out of the 4, you have to attempt that question. अगर चारों में से कोई भी ऑप्शन रूल आउट नहीं हो रहा है, कुछ नहीं समझ हो रहा है, only then you leave that question. ठीक है, so that's all from my side. Thank you and all the very best for your exam.